A little rough today. All right. Good evening, everybody. It's Tuesday night here at Trumbull Regional Medical Center, and you know what that means? That means Matt and Larry are in the basement broadcasting like a pirate radio show. Tonight, we have a subject and a speaker that's going to be worth a lot to everybody here, and it's a very pertinent subject. We've all been waiting around to offload ambulances, and there's been arguments and hurt feelings and all that good stuff. Tonight, Doug Wolfberg from Page, Wolfberg and Worth is here to answer some questions about EMTALA, and he might even take a couple questions on other subjects too. I've never met Mr. Wolfberg myself, but we've all read his stuff and used his forms and all that good stuff. This firm is all throughout EMS and is probably the premier EMS attorney in the nation. So, really glad to have you today, Doug. I appreciate you taking the time out of your schedule to educate us and enlighten us on some things from your world and what affect our world. I encourage everybody to ask a lot of questions and to get into the conversation and try to learn. So take it away, Doug Wolfberg.
Hey, thanks. First, let me ask you, are you guys seeing me okay? And hearing me okay?
Yep, you're just right.
Okay, great. But let me ask you one other question. Is the PWW in the corner reversed or the right way? Because it looks reversed on my preview screen.
You're correct.
Awesome. I love it when a plan comes together. The only other thing I may need some assistance with is, believe it or not, I have been on a million Teams meetings, but I've never done death by PowerPoint on Teams. So looks like if I click the share content button and do that you'll see my screen. Is that what you're seeing?
That's correct. We see your screen and then we see you up in the corner.
Okay. And are you, I have a dual screen operation. So are you just seeing the single slide and not the one that has the two slides on it?
No, I'm just seeing the single slide.
Damn, I did it all right. Okay. Well, I'd rather be lucky than smart. So, all right. Well, thank you guys. And it's a pleasure to be here and to tackle this topic with you for the next few hours. And I am absolutely happy to answer questions, not only on this, but on any legal topics or questions you might have on negligence cases, liability, just drug cases. There was the big case in Colorado where the medics got indicted after the ketamine death. So lots of things going on in the legal side of EMS. And I'm happy to talk about any of those things. But tonight, the subject that we have prepared is EMTALA, APOT, which I'll define, and emergency department diversions. So I'm going to take a minute to briefly introduce myself. And I never like to assume anybody knows who the hell that I am. So I have been in EMS literally my whole life. I actually responded to my first ambulance call in 1978. And the earliest proof, like record that I have of my involvement in EMS, though, is this newspaper clipping from 1980. And that's me right there under the Star of Life on this picture. And you can see there's a guy kneeling like in front of me with his back to the camera, has a hat on and an old Dynamed jacket. That's actually my older brother, who was the original EMT of the family and got me involved in it at a pretty young age. So 40 whatever years, it's a clip from my high school yearbook. Even I was a EMS nerd, maybe is the right word, in high school. And I stayed in EMS all through college. Here's a picture of my college EMS crew like I said, this was a long time ago. Just kidding. I went to Penn State. Sorry, I know there's probably some Buckeye fans or other schools on the call here, but I am a Penn Stater. But in my own defense, Penn State was independent when I was there. That's how long ago it was. It was in the 80s. We were not a member of the Big Ten, so you don't have to hate me on spec. And now I am a lawyer, and it's only 99% of lawyers that give the rest a bad name. All right, so just keep that in mind. But I'm an EMS lawyer, so I like to say we're in the 1%, right, of good lawyers, because all we do is represent EMS providers. So about 22 years ago now, we started Page, Wolfberg, and Worth. This was our original photo of the three founding partners. This was a long time ago. I'm on the guy on the left, but in the middle, it's Jim Page, or James O. Page, a name that I think still a lot of folks know in our industry. Jim passed away in 2004, but he was the guy who started GEMS, and he was deeply involved in the television show Emergency, and did a whole lot of other things in his career in addition to being an EMS lawyer. And on the right is my partner, Steve Worth. So that was the original firm picture, and this is what we look like today. We have the whole firm now, and all of our coworkers and colleagues. So it's just a group of lawyers and consultants and support staff that are just focused entirely on EMS. We don't sue EMS agencies. We don't, all we do is represent EMS agencies, whether they're hospital-based, municipal, private for-profit, nonprofit, and then all the kinds of businesses that work in EMS, like billing companies and others. So all of those kinds of organizations are the clients that we work with in the field. Okay, here's what we're going to talk about tonight, and that is we're going to start with an overview, identify some root causes of this issue. We're going to go through in what I hope is not excruciatingly painful detail, the EMTALA statute and regulations. We're going to talk about some important guidance from the federal government from an agency called CMS. We're going to talk about some actual case studies that have arisen under EMTALA. I find that EMS folks, we like our case studies, so we're going to do a few of those. We're going to talk about something called CID, or Collaborative Informed Decision Making, when it comes to choosing hospital destinations. And then we're going to do some practical Q&A where we have some questions that we have been very commonly asked, already sort of pre-queued up, and then we will have time for any questions you have. And, during the program, if you have questions throughout, I will be looking at the questions, here and there throughout the program. So I hope I'm looking at the right place, but you can put those questions in as we're going along. Okay, so that's what we're going to cover. So we're going to go ahead and start with a little bit of an overview of this issue and some root causes. And let me say this, I want to thank the folks at Trumbull. I mean, I know this is a program that's being made available by the hospital, right? So our hosts are hospitals, a hospital. And, it's going to sound a lot like we're going to fit horns on the hospitals here tonight. I'm an EMS lawyer. My clients, our clients are in EMS, right? So that's the perspective that we come from. And to the extent you may hear some things that reflect negatively on hospitals, let me say that of course doesn't necessarily mean that's what's going on here, right? The presentation has a national focus. These are things that we have observed and issues that we've worked on all across the country, but there are some hard truths, and there have been some things that some hospitals around the country have done that I think EMS needs to be wary of. So that's the perspective that I'm coming at this from tonight. It's not meant to be critical of the hospitals in general, and I'm certainly not in any position to suggest whether any of that is going on in your service area with your hospitals, but I just wanted to make sure I acknowledge that. It's not anti-hospital, folks, it's pro-EMS. Now, we have some photographic proof of this diversion problem, and I thought I'd show it to you. This explains a lot. You know, the nurse is saying, we don't want you to come here, we're too busy, right? But let's talk a little bit about why emergency departments are overcrowded. Well, in this, you know, picture's worth 1,000 words, in this case, a graph. But, you know, there are some data available through NEMSIS. Now, I know you guys have all heard of NEMSIS. You all probably curse NEMSIS under your breath for all the data elements that we have to collect and report on a patient care report. But NEMSIS has a goldmine of data. And one of the things that they do have the ability to track is patient offload times. And you can see, just particularly since the pandemic, how those offload delays have stacked up. And even though COVID numbers are coming down, the offload delay problem has really not abated. We're still seeing that pretty significantly all around the country, even areas that you wouldn't expect, you know, are having this issue, right? And, you know, we tend to use the term hospital bed delays, but we're talking about the same thing, right? Ambulance patient offload delays, or, you know, whatever you want to call it. But these delays endanger EMS systems, right? Because every unit hour that an ambulance is spent waiting in an emergency department is an hour they're not available for responses in the community, right? So it really has a ripple effect on EMS systems. And whether you're volunteer or whether you're a career paid system, for profit, nonprofit, doesn't matter. The single most expensive thing we do in EMS is deploy, right? So the cost of having ambulances ready for response and having staff members and practitioners available and all the other things we need to do. So if I have to add unit hours of deployment because ambulances are spending so much time being held up at emergency departments, that's a significant expense. And our payers, right, Medicare and Medicaid and commercial insurers, they don't pay us for that out of service waiting time. We get paid for transports, which is a ridiculous thing that has to change, but that is the way reality is. Now, hospital bed delays harm patients, right? There are studies, there's peer-reviewed data that draw a clear relationship between these delays and adverse patient outcomes. And these delays take a toll on our people, right? Now, I was in a conversation with somebody, a state EMS director today, not in Ohio, but in another state, who said, you know, some of these crews, we hear that if they have to sit in an ER for 4 hours, so be it. Then they don't have to go out and do anything else. They love it, right? Well, I don't think that's really reflective of why we all got into EMS, right? I sure as hell didn't get into EMS to sit in an emergency department for hours waiting with, you know, what are primarily low acuity patients, right? I mean, if a patient was a trauma or cardiac arrest, they wouldn't be waiting in the wall for 4 hours. So these take a toll on our people. You know, there's burnout, there's high turnover. We have the pandemic that exacerbates all of that. And we can't pay people what, you know, they're worth because the reimbursement and the revenues just don't keep pace with what that we need them to be. So those are just high level looks at the problem. But the other thing I want to say that sort of picks up on my discussion earlier, that this isn't anti-hospital, it's pro-EMS. And before we're going to talk a lot about unilateral solutions, things that EMS agencies have the legal right to do if their hospital partners won't work with them, right? But that said, you know, we don't want anybody to listen to one of our training sessions or one of our webinars or whatever it is, or read one of our articles and go out and say, oh, these EMS lawyers told us that we can tell you to, you know, go screw yourself, we're leaving. Collaboration, folks, is the key here. And working with your hospital partners, EMS and hospitals collaborating to do what's right for both components of that system, hospitals and EMS, but more importantly, what's right for our patients. That's the best way to do this. You know, engage, you know, you don't have to shout at the folks in the ER. They may not be getting the resources from the upper echelons of the hospital administration that they need. The hospital's compliance officer or CEO, they need to be aware of these things. So make sure you open the right doors, have those collaborative discussions, and work together to solve these problems. That said, we're going to get into some issues and some solutions that EMS can employ on its own if hospitals aren't cooperative in that regard. Now, another reason that we're going to tackle this topic the way we are tonight is that collaboration is great, but it has to occur from a level playing field, right? And let me explain what I mean by that. If hospitals are telling EMS agencies that they are not permitted to leave once they bring a patient to a hospital until we say you can leave, right? And if EMS believes that, it's not a level playing field. And we're going to talk tonight about what the law actually says about EMS obligations once you have brought a patient to the hospital. So have those discussions, do that collaborative problem solving, but both parties have to come at it knowing what the rules are, right? You can only have those productive discussions when there is a level playing field. So that is our main objective tonight, to make sure that everybody understands what the rules are. So when these parties come together and talk, they're both on the same sheet of music, okay? All right, and that playing field can only be leveled through education of all of these parties regarding their legal rights and their obligations. All right, let's talk a little bit about the root causes of this. None of this is going to be a big surprise, folks, but it is a complex and sometimes interwoven set of factors that have caused this problem. And some of these are not the fault of the hospital. It's important to understand that. They're not the fault of the EMS system. They're not the fault of anyone else. But some of these root causes are on the hospital, and they need to take ownership of those where that is appropriate. Look, folks, something that none of us can do anything about is high demand. Even though there have been changes in the healthcare system and the Affordable Care Act and all these other things, a lot of folks still don't have primary care, right? They don't have regular physicians or doctors or places that they can go. So a big chunk of emergency department utilization and EMS utilization, for that matter, is probably unnecessary utilization just because of unavailability of primary care. So we have a lot of overutilization. We have understaffed emergency departments. Now, part of that could be that hospitals are, don't want to spend more than they have to. Part of that could be they can't find the people, just like EMS has that same issue. Those are some issues that may or may not be in their control. But we have also seen poor physical design and layout of emergency departments, poor patient flow. Why is somebody tying up a bed for 2 hours when they're simply waiting for labs to be discharged, right? Why are we tying up a bed in the ER when all we're waiting for is the inpatient room to be cleaned so the patient could be admitted, right? So flow issues have contributed to this. And the consequences, we know that there's delays in patient care. There's evidence that suggests there are compromised outcomes, patient outcomes. There's backups and delays in the EMS system. And in some areas, this isn't as prevalent in Ohio and Pennsylvania, where I'm located, and states on the East Coast, but out west in California and other states, EMS operators, the ambulance services, are penalized for response time violations. And sometimes those are beyond their control because of all the unit hours they spend sitting in emergency departments. There's, as we said earlier, frustration, burnout, and all those things that come with it. Okay. Let's see here, folks. Okay, let's talk about the EMTALA statute and regulations. And I'm just, pardon me here, I'm trying to make sure I'm on the right screen so that if there are questions, I will see them. I don't know if there are any yet, but I'm not seeing any, so maybe that's the way it's supposed to be. Okay, we're going to start talking about the EMTALA statute and regulations, because that's the federal law that sort of controls all of this. All right. And that law stands for the Emergency Medical Treatment and Active Labor Act. It's a federal law that applies to all hospitals that participate in Medicare, which is virtually all hospitals because they all want Medicare money. And for that reason, this law comes under CMS. And I used that acronym before, but it stands for the Centers for Medicare and Medicaid Services. So that's the same agency that, pays Medicare claims, right, or oversees that. Now, this law, EMTALA, permits civil lawsuits against hospitals. It does not permit civil lawsuits against physicians, but the government can impose penalties on physicians, civil monetary penalties, and that sort of thing. Okay, so this law was passed by Congress in 1986, and it was in response to a whole bunch of media reports around that time. I was working in EMS at the time. I remember when the law was passed and reading about it. And, we were hearing a lot of stories about patients being turned away from hospital emergency departments, mostly in urban areas. And sometimes these were patients who were in active labor, which is where the law got its name, because these folks didn't have insurance or could produce no financial responsibility and had no ability to pay. And prior to the law being enacted, there was actually no federal legal requirement that a hospital emergency department accept a patient. And the first procedure that would be done when a person came into the ER was called the wallet biopsy, right? Do they have an insurance card, right? And if they didn't at the time, there was no law that said the ER had to take them. And, for better or for worse, ground zero for this law was really the city of Chicago. That's where a lot of the stories, the horror stories about patient dumping seemed to arise. So let's take a walk through the EMTALA statute and the regulations. The statute, of course, is the law. Regulations are published by the federal agency, by CMS in this case. Those regulations also have the force and effect of law. And some of this, as we're going to see here, folks, are not entirely clear, or as clear as we'd like them to be. All right, so let's first start with the statute. And you have to be of a certain vintage to appreciate the image here. I hope a lot of you recognize Schoolhouse Rock, right? Now, a lot of these slides are pretty dense. So what we've done is on the left side of the slide, we have sort of the statutory language. And then we know EMS folks like to say, all right, that's a bunch of legal BS. Tell me what this really means. So we have a box that says what this means, right? I should have called it what this BS really means. All right. So the EMTALA statute first has a medical screening requirement. And what that says is basically when any patient, now let me stop right there with the first three words, right? When any patient. Now, I mentioned earlier that Medicare is the agency that enforces this law, but it doesn't just apply to Medicare patients. It applies to anybody, right? So the feds, what they did was they used the Medicare money as the hook. If you want Medicare money, you've got to do this for all of your patients, all right? So any patient, regardless of whether they're on Medicare, regardless of their ability to pay, comes to a hospital emergency department and either wants care or needs care, or any reasonable person could look at them and think they want care or need it. The hospital has a legal duty to examine the patient to find out if that patient has an emergency medical condition. And that is defined in the law, and we'll get to that in a few minutes. Now, folks, if the hospital does that screening examination and concludes that the patient does not have an emergency medical condition as defined in the law, that hospital's EMTALA obligations are over. They're done. They're finished. All right. If a hospital says, all right, we've screened you, you don't have an emergency medical condition, we're not going to take care of you now, go somewhere else, they would be well within their rights under this statute to do that. Now, folks, could that be medical malpractice under state law? Sure. But under EMTALA, the duty is to provide a medical screening examination to determine if an emergency medical condition exists. If it does, additional duties arise. If it doesn't, their duties have ended. But they have to do that medical screening examination to find out, right? So that is the first duty that's imposed on the hospital. Okay, now let's talk about what happens if the hospital does that screening exam and concludes that the patient does have an emergency medical condition. If the hospital concludes that the patient does have an emergency medical condition, the hospital has basically two choices. They got to do one of two things. They have to provide the care necessary to stabilize the patient, or they can transfer the patient, but only if that transfer is appropriate under EMTALA. Okay, so we'll explain what all that means in a little bit more detail. But on the first point, if the patient has an emergency medical condition, the hospital has to provide stabilizing treatment. But it's important that we understand that that's only within the hospital's capabilities, right? EMTALA doesn't say, well, every hospital must have a neurosurgeon in case a patient comes in with a head injury. What EMTALA says is if you're a small community hospital and you don't have neurosurgery, you have to use what you do have to try to stabilize the patient. But if you need to send out the patient because they can't be stabilized unless they get some specialized care, that is the type of appropriate transfer that EMTALA is talking about. Okay, let's talk about a patient's refusal to consent. If a patient or their legally responsible decision maker, okay, so if it's a minor, their parent or legal guardian, if it's an incapacitated adult, their POA or their legal decision maker, so either the patient or whoever that it is that has a right to make their healthcare decisions can refuse care in the ER, or they can transfer out and say, I'm out of here, I want to go somewhere else against medical advice or AMA. The hospital's duty in that case is to attempt to obtain written informed consent of that patient's decision, okay? If the hospital does that, it will not violate EMTALA if a patient chooses to exercise their own decision-making rights to go somewhere else or to refuse care. Now, if the patient has an emergency medical condition and the hospital has not yet provided the treatment necessary to stabilize that condition, transfers of that patient out of the hospital are prohibited by federal law, okay? This is why it's called the patient anti-dumping law, right? That's kind of a lot of times what the media calls this. If the condition is emergency and hasn't yet been stabilized, the hospital cannot transfer the patient unless the legally responsible decision maker or the patient requests the transfer, right? And that's informed consent in writing. Or a physician has signed a certification that the benefits of the transfer outweigh the risks, okay? So for example, this would be used by a community hospital receiving facility, non-trauma center, if the patient requires stabilization that could only be done at a trauma center, let's say, whether it's neurosurgical, whether it's cardiothoracic, whatever that is. And the receiving hospital simply doesn't have the capability. And there's nothing that that ER doc can do to stabilize the patient unless somebody goes in the head, goes in the chest, right? Does those things that we can't do. In that case, that attending physician can sign an EMTALA transfer certification that says, this is a patient with an emergency medical condition, and yes, they have not been stabilized yet, but they have to be transferred if they have any hope of being stabilized. And in my opinion, the benefits of that transfer outweigh those risks, right? So that's called an EMTALA transfer certification. And in those circumstances, a physician can transfer an unstable patient with an emergency medical condition. Now, the EMTALA law and the guidance also talk about what is an appropriate transfer. So first, the transferring hospital, the one that's sending the patient out, has to do everything within its capabilities to care for that patient. Then the receiving facility has to have space, qualified personnel, and has to agree to accept that transfer. Medicare also says that a hospital that has specialized capabilities, now we're talking trauma, peds, right? Whatever, stroke center, STEMI center, those specialized facilities cannot refuse an appropriate transfer if they have the capacity. So that is an obligation on specialty facilities. Okay, and now this starts to get more into EMS, right? That transfer also has to be accomplished using appropriate transport resources. So the sending hospital has a legal duty to ensure that it selects the right resource to get the patient to that destination. Now, that's all dependent on the patient's condition. It might be appropriate to use a BLS ground ambulance, an ALS ground ambulance, a ground critical care unit. It may require air medical transport. So the sending hospital has to make the determination what level of service does that patient require during transport, and the hospital even has to assess whether or not it may need to send personnel along with that transport unit to be able to provide effective care to the patient until such time as they are received at that receiving facility. Okay. Now, I promised you I would define the term emergency medical condition. And here's what it is. There's a lot of words to it, but basically a emergency medical condition is a condition that could reasonably be expected to result in, and you see the term reasonably, right? So this is kind of a bit of like what a prudent layperson would conclude, right? If a reasonable person thinks that this could go bad, then it's an emergency, okay? Now, anytime a condition could place the health of the person in serious jeopardy, and that also includes an unborn child in the case of a pregnant woman, any condition that could result in serious impairment of bodily functions or serious dysfunction to some part of the body, all of those are emergency medical conditions. Now, if we're talking about a pregnant woman, if the woman is having contractions and there's not enough time to effect a safe transfer before delivery, or the transfer may pose a risk, those are what we call per se emergency medical conditions. So basically, a woman in labor is an EMTALA emergency medical condition. And again, that's why the name is the Emergency Medical Treatment and Active Labor Act, right? Because active labor is really one of the purposes the law was passed. ERs can't turn women away who are in active labor. Okay, now a few slides ago, I said that the hospital's duty, if they find the patient has an emergency medical condition, is to provide the treatment necessary to stabilize the patient's condition. The definition of stabilize means that no material deterioration of the patient's condition would be likely, okay? That's what the legal definition in the law is of the word stabilize. Okay, let me look at my screen here. Hey, if somebody wouldn't mind just putting a test question in the chat, just write the word test or something. Just one. I know everybody will do it because nobody knows who else is doing it, but maybe one of our organizers do that. Thank you. I got it. Okay, I'm on the right screen if anybody has any questions. So I'll be trying to pay attention to that. Nobody else needs to send a test. Thank you. We're all good. But if you do have questions, please feel free to ask those at any time. And if one of the organizers also wants to put in the chat, I'm sure you get breaks at some point. I don't know what your normal approach is, if you do them on the hour or just halfway through or whatever, just let me know that too, because the brain can only absorb what the butt can endure, ladies and gentlemen.
Yeah, we usually take a break whenever it fits in with your lecture. And I also monitor the chat box in case you get anything coming up. I'll let you know.
Cool. Thanks.
No problem.
Okay. All right. We'll press on for a little bit here. We're going to go through the EMTALA related regulations. Okay. Now, the regulations get into a lot more detail than the statute does. All right. Now, the statute says that the hospital has to give a medical screening examination to somebody who comes to the emergency department, right? Well, there's lots of rules and regulations that further define what it means to come to the emergency department. I know that seems like a straightforward phrase, but as you're going to see from the regulations and from some of the case law, it's anything but straightforward. Okay. Now, certainly a person who physically shows up in a hospital emergency department and asks for care triggers the hospital's EMTALA obligations. Okay. And it does not matter, folks, and this is going to become important a little bit later in our session. It does not matter how the patient got there. Their physical presence on the hospital's property in the ER, particularly, triggers the hospital's EMTALA obligations. So it doesn't matter if they walked in, if they were driven by a family member, if they showed up in an Uber, if an ambulance brought them, right? How they got there is irrelevant. Physical presence of a person in the emergency department asking for care triggers the hospital's EMTALA obligations. The second way is if a person presents anywhere on the hospital's property other than the emergency department, and anybody who looks at that person might conclude, hey, they may have an emergency going on, right? That also triggers the hospital's EMTALA obligation. So if a person wanders into the gift shop, right, and goes, oh man, my chest, I can't breathe. Any reasonable person, even the cashier behind the cash register, doesn't have to be an RN or an ER physician to go, oh, well, I don't know. It could be an acute myocardial infarction, right? No, anybody that would look at that and go, holy crap, you need help, right? That also triggers the hospital's EMTALA obligation. Now, the cash register clerk doesn't need to do the medical screening examination. They're not qualified to do that, but they do need to have the wherewithal and the training to be able to activate whatever the hospital's policy is to say, hey, I'm in the gift shop and we need help here, right? And get that patient to the emergency department so that that screening examination could be done. Call for whoever, you know, in the hospital would help move that patient to the ER and do that promptly. Okay. The other way that a person comes to the emergency department for triggering the hospital's EMTALA obligation is if they're in an ambulance. All right. Now, this is where we start getting really EMS focused under EMTALA. All right. Let's first take the easy one. And the easy one is if the patient is in an ambulance that's owned and operated by the hospital, whether it's a ground ambulance or an air ambulance, they have come to the hospital under EMTALA. That hospital-owned ambulance is hospital property, okay? So, and that duty applies even if the ambulance is not yet at the hospital emergency department. So wherever that hospital-owned ambulance goes and picks up that patient has come to the hospital for purposes of EMTALA, okay? Now, there are some exceptions, just like any good federal rule, right? If that patient is in a hospital-owned and operated ambulance, but there's an EMS protocol that says the patient should go somewhere else, the hospital does not have to take that patient back to its facility, okay? In most cases, the ambulance, the hospital-owned ambulance, does have to take the patient back to its facility for that medical screening examination. But if there's a protocol, and the regs call that a community-wide EMS protocol, that means not the hospital's own internal made-up protocol, but something that the EMS Council or the state EMS office or some regional EMS agency, an oversight body, has put into effect, the Regional Medical Advisory Committee or whatever you call it. Under those protocols, if the protocols say go somewhere else based on the patient's condition, that's not an EMTALA violation. So quickest example, An ambulance owned by a community hospital that's not a trauma center picks up a patient who meets trauma criteria under the protocols. The protocols say go to a trauma center, don't go to a community hospital. That hospital-owned ambulance bypassing its own facility and taking the patient to the trauma center would be perfectly fine under EMTALA because that's what the clinical protocol says. Okay. The other way that a hospital-owned ambulance can go to a different hospital is if they're given an online medical command instruction to go elsewhere. But please note that the regulation says that that order has to come from a physician who's not employed or affiliated with the hospital that owns that ambulance. So in other words, to divert an ambulance away from the hospital that owns it, a medical command physician has to be from another facility or another healthcare system to give that order, okay? Otherwise, it could be a way around the whole anti-dumping provision. Okay, now let's talk about the majority. Oh, sorry, is there a question? Or just an open mic? Okay, if you don't have a question, if you wouldn't mind closing your mic, please. Thank you. All right, now let's talk about the majority of ambulances in the United States, which are non-hospital owned and operated, okay? So let's go through the EMTALA regulations that apply to non-hospital owned ambulances. If the person is in a non-hospital owned ambulance, ground or air, and that ambulance reaches the hospital's property with that patient, the hospital's EMTALA obligations kick in, all right? So a non-hospital owned ambulance on the hospital's property triggers the hospital's EMTALA obligations. Hospital property, by the way, has a pretty expansive definition. It's not just the ER. It's the main hospital building, contiguous buildings, and anything within 250 yards of that, right, is actually the federal legal definition of hospital property. Okay, now, if I have a patient in a non-hospital owned ambulance and they're not on the hospital's property, that patient is not considered to have come to the emergency department, even if a member of the ambulance crew contacts the hospital by radio and tells them they want to bring the patient to that hospital, right? That contact alone does not raise a hospital's EMTALA obligations. There's a huge but here, folks, and you're going to see that when we get to the case law in a few minutes. The next important rule for EMS, for non-hospital owned ambulances, is that a hospital may divert the ambulance to another facility. So here's where we're at now, just keep track. Non-hospital owned ambulance contacts the hospital, says they're bringing the patient to that facility, and the hospital wants to divert the ambulance. The hospital can give a diversionary instruction to the incoming non-hospital owned ambulance if, and yes, we bolded, underlined, italicized, and highlighted the word if, because you're going to see that in a case again in a few minutes, if the hospital is on diversionary status. Diversionary status is not an arbitrary term. It's not just when a hospital says, I say there's diversion. Diversionary status is defined in the federal regs to mean the hospital lacks the staff or the facilities to accept additional emergency patients. Okay. Now, folks, the reg goes on in the very next sentence to say this. If, however, the ambulance staff disregards the diversionary instruction and brings the patient to that hospital, the hospital has an EMTALA obligation. So remember, earlier we said it doesn't matter how a patient gets to the emergency department, personal vehicle, Uber, ambulance. When the patient is physically on the hospital's property, the hospital's obligations apply. So what this section of the rules make very clear is that diversionary orders are really requests, right? A hospital has the right to ask you to divert if they are on diversionary status, but an ambulance still has the legal right to bring a patient to that hospital. Now, folks, I am not saying that that's always the best idea. If the hospital really is unable to care for your patient, it's not going to benefit your patient to go there. But the regs are very clear on that point. All right, and this is called different things in different systems: diversion, bypass, rerouting. But at the end of the day, as we said, a diversionary order is really a request under federal law. Okay.
Hey, Doug.
Yeah.
This is Larry. There's a question posed in a chat, and just because you were talking about hospitals. So Liberty Township is a fire-based EMS, and downtown in Youngstown, they have a level 1 trauma center who have completely got rid of their OB services. So a lot of times, Liberty Township Fire Departments will take a patient in active labor, have to drive past that hospital and go 20 minutes beyond that hospital to the neonatal or to the OB center. So the question was asked, does St. E's have to, does that big center downtown have to take a patient in active labor versus going all the way 20 minutes away to the OB center?
Yeah, good question. The answer is yes. If you take the patient there, they have to take them. If they hold themselves out as a hospital emergency department, they may prefer not to take OB patients. They may ask local EMS agencies to go elsewhere, and it's perfectly fine. And your patients may prefer to go somewhere else if this hospital doesn't have OB capabilities. But if you take a patient there and it's an emergency department, they have the legal obligation. They may not want them, but they absolutely have the legal obligation. So I hope that answers the question. Okay, and folks, we're going to talk a little bit more about strategies for destination decision making a little bit later. So we can come back to that. All right, so I mentioned that once the hospital's EMTALA obligations kick in, they have to do a medical screening examination. Now, I'm often asked, well, if it's a hospital-owned ambulance, can't the ambulance crew just do that and decide if it's an emergency medical condition? I mean, clinically, they probably could, but legally, no. It has to be, in most cases, a physician, and only in certain cases can a hospital approve nurses to even do that. So the nurses may do triage and that kind of thing, but the medical screening examination for purposes of EMTALA typically has to be a person who is credentialed under the hospital's bylaws to do that, and that normally has to be a physician. Okay, the third piece, and I just saw another question. If something goes wrong between Maine and Boardman, would the crew be held liable? Yeah, let me sort of put a pin in that question, because one of the 3 cases that we're going to do in a few minutes is a scenario where there is liability that sort of boomerangs back to the crew, and not in an OB case, but in a different case, and it may help illustrate the point. We'll come back to that in a few minutes. All right, the third category, we have the statute, we have the regulations, and now we're going to talk about some CMS guidance. One rule deals with helipads, and we get asked this a lot. What if I take a patient to a hospital just to transfer them to a helicopter to go to a trauma center because the local hospital has a landing zone or a helipad? In this case, and there's background on this, and I'll make sure that Larry and those folks get these handouts, so you have a copy of all this. I know they're not available as of right now, but we'll get these to you. But basically, the government has said it's okay to use a hospital merely as a transfer point from a ground to an air ambulance. And we have heard sort of these stories, horror stories in some cases, of ambulances trying to do just that, right? Hey, we're just trying to offload them from ground, get them in the helicopter, get them to the trauma center. When a ER doc might come out and say, well, now you're here, I have to take this patient and see them. You can't leave, and by protocol, we know this patient needs to get to the trauma center. They're wasting time at a non-trauma facility. So CMS has said that first hospital does not have EMTALA obligations where it's only being used to transfer the patient, unless the patient or somebody on the patient's behalf asks for that care to be provided. Otherwise, hospital can be used simply as a transfer point. Okay, let's talk about one of the more controversial and current issues, and that is the wall time issue. And CMS has also given us some very clear guidance on this. And so I'm just going to read you some of the major parts of these. There's a lot of stuff in this manual. But one of the issues, as we sort of talked about in the introduction, is when hospitals say, hey, you've got to stay with this patient. You brought him in, so you've got to stay with them until we accept them and say we're accepting care, right? Otherwise, it's abandonment or it's not a proper handoff of care. Well, CMS has spoken to this, and they say that hospitals that deliberately delay moving a patient from an EMS stretcher to a hospital bed do not delay the point in time at which their EMTALA obligation begins. And some hospitals incorrectly believe that as long as we say that that patient has to stay on the EMS stretcher, we don't yet have an EMTALA obligation. That is completely incorrect. Okay. Arrival of the patient on hospital property triggers the hospital's EMTALA obligations. And then CMS goes on to say that that practice of parking patients with EMS is a violation of the Medicare conditions of participation. Now, to be fair, that guidance also says this. On the other hand, this does not mean that a hospital will necessarily have violated EMTALA if it does not, in every instance, immediately assume from the EMS provider all responsibility for the patient, right? So CMS, what happened was that first guidance here, right? They put that out a couple of years earlier. And a lot of EMS providers kept a copy of that, like in the cargo pocket of their duty pants, and would say, "See, we don't have to stay," right? So CMS sort of issued this subsequent guidance to say, "Well, wait a second. It's not always reasonable to expect that the minute you walk into an ER, the hospital is standing by and ready to take your patient. We know that's not the case." They know that there's situations where hospitals are overburdened and don't have people available at the time. Here's what they say about that, however. So if an EMS provider brought an individual to a dedicated emergency department at a time when the ED staff was busy with other things, it could, under those circumstances, be reasonable for the hospital to ask, also bold, italics, and underline, the EMS providers to stay with the individual until such time as the ER can accept treatment. So a couple of things here, folks. First, notice that this guidance says if the hospital is occupied dealing with multiple major trauma cases, right? What it doesn't say, if they're dicking around with 10 people in the ER with the sniffles, they can make you wait. It says if they're occupied with serious stuff, okay? So it's clear that asking EMS to stay with patients should be the exception, not the rule. The second important thing about this paragraph is the word ask. And clearly the word ask brings with it the ability to refuse, okay? So it is clear that hospitals can certainly ask EMS to stay, but they cannot require it, okay? That's the specific reason the federal government chose the word ask. Okay, a question that came up, what if we're being parked and requested to take the patient for x-ray or CT or other hospital procedures prior to a room? Folks, it's really the same issue. And the point that we really want to make, and we'll get into this a little bit later, is that once you bring the patient to that hospital, whose patient is it? It's the hospital's patient. Anything you now do for that hospital, that patient, is voluntary. So if you start moving patients around, that's normally the job of hospitals, orderlies, or conveyance staff, right? Patient movement. They can ask you to do it, but you do not have a legal obligation to do that. And quite honestly, folks, we're starting to work with a lot of clients around the country, particularly in California, but in other states as well, that are now going to their hospitals and saying, okay, if you want to keep our EMS crews there to care for your patients, right? Here's what it's going to cost. Here's our personnel cost, our unit hour cost, and here's the charge for that. And please sign this agreement. Otherwise, we're not going to do that for you anymore. So we'll talk about that later. Okay. And the hospital also, if it's going to ask EMS to stay with a patient, it also has to make sure that EMS has the capability to do that. If I have a patient with unstable angina and a BLS crew brought him in, I probably shouldn't ask that BLS crew to stay with the patient for 2 hours because they wouldn't have the ability to provide ALS interventions should the patient need that. Okay, so the bottom line on patient parking is it's not always reasonable to assume that the ER can take custody of the patient right away. Make sure they know you're there. Make sure patient care doesn't suffer. But at the end of the day, they can ask, hospitals can ask EMS to stay with the patient, but they can't require it. And they can't also require you to do anything that's beyond your scope of practice simply because you happen to be inside of a hospital. Okay. It's about 7 o'clock. I'll tell you what, let me, we've got 3 cases here. Let me do the first of these, and then I think that'll be a good time to take a break, and then we'll do the second and third cases. All right, so this first case goes back to that regulation that I mentioned, how the mere use of a radio or phone to contact a hospital does not trigger by itself the hospital's EMTALA obligations. This is the case where that rule came from, okay? And earlier I mentioned how the city of Chicago seemed to be where all of this EMTALA stuff arose, and the same is true for this particular case. And this case was decided in 1992, so not terribly long after the EMTALA statute was passed in 1986. And it's called Johnson versus University of Chicago Hospitals. So what happened in this case, it was a pediatric patient, a 1-month-old who stopped breathing. Her mother called 911, non-hospital owned ambulance responded. And during the transport, the crew contacted UCH by radio and saying they were en route with a cardiac arrest, pediatric cardiac arrest patient. A nurse on the other end of the radio told the crew that the hospital was on partial bypass due to a lack of PICU beds. Not a lack of ED beds, but a lack of PICU beds. Infant in cardiac arrest doesn't need the PICU, they need the ER, right? So the ER nurse gave this diversionary instruction to the ambulance, even though the medics told her they were only 5 blocks away at the time. The ambulance did as they were told. They diverted the patient to a more distant facility, one that, by the way, didn't even have a PICU. The patient was stabilized, was transferred to Cook County Hospital for PICU care, but subsequently died. Family filed a lawsuit against UCH alleging an EMTALA violation. The trial court, so in the federal legal system and the state system for that matter, cases first go to a trial court, and then if there's, a decision or a dismissal or something like that, the non-prevailing party, the losing party, can appeal that, right? And that goes to in the federal system, it's called the Circuit Court of Appeals, okay? So the trial court dismissed the case. They threw it out, right? So the family of this infant sued the hospital alleging that they violated EMTALA because they turned the patient away. Now, this is prior to those regulations, right? The court looked at the statute and said, hey, this patient never came to the hospital, okay? And that EMTALA therefore didn't apply. Now, when the case went up to the appeals court reversed the trial court and said the patient came to the hospital when the ambulance crew contacted the hospital by radio, okay? Now, we know that the regulations were changed, so it says that that's no longer the case, but this predated those regulations. And the court ruled that the hospital violated EMTALA by sending the ambulance away after it had called in by radio. Now, something very interesting happened in the Johnson versus UCH case after that decision. And folks, I remember this very clearly. Working in EMS at the time, I was, 92, I was working at the state EMS council in Pennsylvania. So I remember this decision, and I remember thinking, well, any hospital that provides medical command is going to get out of the medical command business because they now have EMTALA obligations as far and as wide as their radios can take them, right? So a lot of people, like, contacted the Court of Appeals and said, hey, you may not have really intended that consequence from that decision, but it was a really bad idea. So the court did something that courts very rarely do, okay? And they withdrew their own ruling. And you see the phrase in here, it says sua sponte. That means on its own. There wasn't a motion or a petition or an oral argument or anything like that. The court issued its opinion and then said, oops, we withdraw our opinion, right? So it was kind of a very fascinating, tortured legal history here. So the lesson from this first case is that a hospital can issue a diversionary request to an income. And by the way, those regulations, I should say, that say a non-hospital ambulance off of hospital property is not deemed to have come to the hospital simply by radio contact, right? Those regulations were written because of this case, right? CMS read this case and said, whoa, that's not what we intended. So they wrote a regulation that had national applicability, okay? And at the same time, CMS wrote that rule saying radio contact alone does not trigger a hospital's EMTALA duty. They added this phrase, this sentence, that a hospital can divert the ambulance if the hospital's in diversionary status. And you see that word if again highlighted, and we're going to see why in the next case. So from this first case, we know that a hospital can issue a diversionary request. The ambulance can accept or disregard that diversionary request, and radio contact alone does not constitute coming to the hospital and does not trigger a hospital's EMTALA obligations. But the second case of Arrington versus Wong will tell us something different. So why don't we go ahead at 7 o'clock? Let's take a 10-minute break. We'll start up at 7:10 and we'll talk about the very interesting Arrington versus Wong case.
Awesome. Thank you, Doug. All right, everybody throw your hands up and we'll see you in 10 minutes. Doug, we make them put their hands up because that just lets us know that they're still awake.
Got it. Well, that's good to know if they're awake. Appreciate that. It's hard to hold attention on a remote session, but we do our best.
I've got a list of questions for you already.
Great. Thanks. Okay, folks, ready when you are. Give everybody a second to get back to their computers here. Okay, let's tackle a couple of the questions that have been put in the chat here before we get to the next case. One was that our department, fire-based, had this occur twice while waiting to be triaged in the ER. The patient required additional medication. The ER was asked if they would administer the meds and refused, and further told our crew not to administer additional meds while on our cot. Our crews identified the need for the drug and contacted medical control, who instructed the crew to administer the additional meds, which they did. Was our crew correct in contacting medical control and following their orders and ignoring receiving hospital's order not to treat while on our cot? Absolutely. I think, again, you did the right thing for the patient. I think the hospital was in the wrong here by not providing needed care to a patient in their facility when it was their duty to do that. I would have advised a client who asked me that question to do the exact same thing. The next question is, does the street in front of the hospital constitute hospital grounds? I have been to an MVA directly in front of a hospital and was told that the patient had to be transported to that hospital due to EMTALA. So the answer on does the street in front of the hospital constitute hospital grounds? It depends. There's that legal definition of hospital property. If it falls within that 250 yards of the campus, yes, it would. But the federal government also doesn't require, the ER staff to put on turnout gear and go out and extricate because it happened on the road, in front of the hospital. And no, there is no requirement that the patient be brought to that hospital simply because the crash occurred within 250 yards of the hospital's property. If your crew gets there, and assuming you're not a hospital-owned ambulance, because then you would have a duty in most cases to take them back to that hospital. Assuming you're not hospital-owned, you're free to take the patient anywhere. It's not an EMTALA violation. Certainly that would be the closest one, though, at the time. Okay, the second case study here is called Was Dr. Wong Wrong? And this is out of the Ninth Circuit Court of Appeals, which covers most of the Western United States. And this particular case came out of Hawaii, actually. And every time I teach this case, I have to just quietly thank Mr. Arrington, who I didn't know. But little quick story here. This case was decided in 2001, and not long after that, the EMS director in Honolulu, who I knew, said, hey, could you come over to Hawaii and do a seminar on this stuff for us? And I said, oh, darn, come to Hawaii. So sure. And then it was my good fortune that sitting in the audience at that seminar was the state EMS director, who said, this was great. Can you come to our conference next year and, at the state conference and do this? Sure. So back to Hawaii and did another talk, and then was asked back for like the next 8 of those in a row for about another 8 years. So thank you, Mr. Arrington. A lot of Hawaii time because of this case, but unfortunately, Mr. Arrington's no longer with us. Okay, what happened was in 1996, so this is about a decade after EMTALA, Mr. Arrington, who was 69 years old at the time, experienced shortness of breath on his way to work. He got there around 11:30 p.m. He arrived at work, and one of his coworkers called for EMS, realized he wasn't in very good shape. And an ambulance that was non-hospital owned and operated, it was city and county of Honolulu, responded. So when they arrived, they found the patient had complained of a sudden onset of dyspnea. He had a history of hypertension. He was found kneeling on the floor. He was kind of leaning into a couch. He was in severe respiratory distress, could only get a word or two out at a time. His pulse was 100. The monitor showed sinus tach with ectopy and respirations at 50. His pressure was up, his GCS was fine, and the crew's clinical impression was CHF or MI. So they initiated treatment at 10 liters, bumped it up to 15, hit him with nitro spray, started an IV, and gave him Lasix and albuterol. So they began to transport the patient to the closest facility, which was Queens Medical Center, or QMC, at 24 minutes after midnight. And about a minute later, they got on the radio and initiated medical communications with the hospital, speaking with an ER physician named Dr. Norbert Wong at Queens Medical Center. And here is what the actual communication said. We're en route to your facility, 69-year-old male, about 125 kilograms. He's in severe respiratory distress, breathing about 50 times a minute with crackles about a quarter of the way up bilaterally. He's very exasperated. JVD is flat. Pulse is 100. BP is 200 over 100. And the crew then repeated. As I say, respiratory rate is about 50. We gave him 1 nitro, started normal saline, gave him 40 Lasix. We have him on a non-rebreather at 15, and he can only talk about a word or two at a time. Dr. Wong's response to all of that was, okay, what's the patient's name and who's his doctor? The crew responded, he's a Tripler patient, which meant the Tripler Army Hospital, which was 5 miles away from QMC, 5 miles further from the ambulance's location. And they said, being that he was in severe respiratory distress, we thought we'd come to a closer facility. Dr. Wong said, if you started the treatment with the Lasix and the nitro, I think it'll be okay to go to Tripler. I think it'll be okay to go to Tripler. The crew responds to that, okay, we'll go to Tripler then. All right, so let's take a look at what happens. Tripler is about 5 miles further away, as I said. They had an ETA of about 5 minutes to Queens when they decided to divert to Tripler. The patient codes about 2 minutes after arrival at Tripler and was pronounced dead at 0117. Exactly 2 years after the call, the family brings suit, not to mark the anniversary, but because they were about to blow the statute of limitations. And the defendants in this suit included Dr. Wong, his physician group, Queens Medical Center, and the 2 EMS crew members, as well as the City and County of Honolulu EMS. Now, you may remember, you may not, at the very beginning of this, I said that EMTALA permits civil lawsuits against hospitals, but not doctors and other parties. So if EMTALA only permits civil suits against hospitals, how were all these other defendants named? The doctor and the EMS providers and the ambulance service? And the answer is, once there's a federal issue in a case, state law claims can be asserted in the same case. So claims like negligence and medical malpractice and all of those can be brought in the same case. Sorry, I got an itch in a spot I really can't reach. Okay. Can be brought in the same case. So if you've ever heard somebody say, what are you going to make a federal case out of it? Why, yes, I think I will. Thank you very much. So EMTALA is a federal law, and if there's a violation of federal law, a plaintiff can go to federal court and they can bring all of their state law claims with it. All right, now just like we saw in the Johnson case first goes to a trial court, okay? The trial court dismisses the case, okay? And they say, look, Mr. Arrington never physically got to Queens Medical Center, okay? And this court said, look, physical presence at the hospital is necessary for EMTALA to apply. And we are going to draw a line that if the patient's not there physically, we're not going to impose EMTALA obligations on the hospital. Now, the case goes to the Ninth Circuit Court of Appeals, which reversed the district court and said, wait a second, we've seen this fact pattern before. In Johnson versus University of Chicago hospitals, the court ruled that coming to a hospital or contacting the hospital by radio triggers EMTALA. The court threw that opinion out. CMS wrote a new rule. The rule says that radio contact alone does not trigger EMTALA. But Do you remember that word in 2 different slides? We bolded, italicized, underlined, and highlighted, and that was the word if. Once an ambulance does contact the hospital by radio, the only time the hospital can direct the ambulance away is if the hospital is in diversionary status. Here, Queens never contended that they were in diversionary status. Go back to the communications, right? Oops, I'm going the wrong direction. I think it'll be okay if you go to Tripler. Is that a diversionary? Is that we are on diversionary status? We lack the staff or facilities to accept any emergency patients. Please go elsewhere. No, that's Dr. Wong going, it's okay, go to Tripler, right? So the appeals court said that wasn't diversionary status. And the only time a hospital can even make that request of an ambulance is if the hospital is on diversionary status, meaning it lacks the staff or the facilities to take an emergency patient. So it wasn't the radio contact that triggered EMTALA. It was the act of the hospital sending the ambulance somewhere else without being on diversionary status that triggered EMTALA in this case, that violated EMTALA. So the court went on to say that the regulation tells us that if the ambulance personnel contact the hospital to tell the hospital they want to transport the patient there for examination and treatment, the hospital may not deny the individual access unless it is in diversionary status. That is, it does not have the staff or the facilities to accept any additional emergency patients. Queens Hospital has not contended that it was in diversionary status at the time Dr. Wong directed Arrington away from Queens and to the more distant Tripler facility. Now, sorry, I put a cough drop in. Let me get rid of that. So let's talk about how the EMS crew got sued for negligence and malpractice here. The things that Dr. Wong said weren't terribly clear, right? I think it'll be okay if you go to Tripler. You know, the EMS crew could have avoided or reduced the chances of liability on them because the allegation against them was that they were negligent in taking what Dr. Wong said as a diversionary instruction, okay? In other words, the very next thing out of the crew's mouth should have been, Dr. Wong, I'm sorry, are you saying that QMC is on diversionary status? Oh, you're not? Well, then we'll see you in 5 minutes, right? Because the crew's clear clinical judgment was to go to that hospital because of the patient's condition and that it was closer. Dr. Wong never said, we can't take the patient. We're too busy. We have no beds. We have no nurses. We have no doctors. Please go somewhere else. He just said, it'll be okay, right? So the alleged negligence on the part of the crew was not confirming that this request was being made based on a true diversionary status, that they should not have overruled their own judgment that the patient needed to go to that closer facility, okay? And diversionary status is based on the hospital's capacity, right? Staff and facilities. So for that reason, we've seen some policies that say, you know, minimum time the hospital, you know, has to be on diversion once they declare diversionary status is 3 hours. Well, what if their backlog is cleared up in 45 minutes, right? EMTALA doesn't say you can declare diversionary status for a block of time. It says diversionary status is when you at that time lack the staff or the facilities to accept an emergency patient. And it's also important that you don't want a Dr. Wong, if you're a hospital, picking up the mic or picking up the phone and just making on the spot, off the cuff determinations about where the ambulance should go if you're directing them away, right? A hospital should have standards, okay? What does it mean for us to declare diversionary status? Whatever that is, 125% of bed capacity, or, you know, nurse to patient ratio of more than, whatever it is, okay? That's, so it's objective. It's not just somebody picking up the, go to Tripler, right? It's sort of based on something that's definable. And the last lesson here is that EMS providers should apply what we call collaborative informed decision-making principles to these patient destination decisions. And for that reason, that's going to be one of the sections that we're going to cover here. So we'll come back to this last one. All right, third and final case study. We'll do this one pretty quickly. Comes out of the First Circuit Court of Appeals in 2008, so a few years after Arrington. This is in Puerto Rico, but it follows U.S. law because it's U.S. territory, and it falls under the First Circuit Court of Appeals. Mrs. Morales was diagnosed as having a non-viable ectopic pregnancy. 2 days later, she had severe abdominal pain and vomiting. She was at work. Her coworkers called EMS. They began to take her to the hospital where her OB physician normally practiced, and it was a non-hospital owned ambulance. So they called into the ER and spoke with Dr. Marquez, told them that they were bringing in the patient and that, you know, she needed care. And he seemed worried that the patient had induced an abortion and stated that he was very busy and asked for some more information and call me back when you have this additional information. So they called again, and this time Dr. Marquez asked the ambulance whether the patient had medical insurance coverage or other types of financial responsibility. The medics said, you know, we don't have that information. And the next thing was click, right? Dr. Marquez abruptly terminated the call after the crew was unable to give assurances of the patient's financial responsibility. Now, the EMS crew interpreted that abrupt termination of communications as a refusal to treat the patient at the hospital. And just like Dr. Wong, Dr. Marquez never claimed that the hospital was on diversionary status, but they took the patient to a different hospital. Here, the court was looking at like Webster's dictionary, and they said, look, this regulation is a bit of a hodgepodge. And I love the language that they wrote this in. Despite assiduous interpretive efforts, its overall meaning remains obscure. You got to love good writing. And they go on to say, presented with an imprecise statute, an unenlightening regulation, and an absence of any clear agency interpretation of what the reg means, this was before the CMS guidance, we must rely on the purpose of the law to interpret this phrase. And they went on to say basically that the Arrington court was right, that saying a person comes to the hospital when they're en route, the hospital's been notified, and they can't turn the patient away at that point unless they're in diversionary status. The court goes on to say if a hospital were allowed to turn away a patient while en route under these facts, an uninsured person could be bounced around like a ping pong ball in search of a willing provider. And that's exactly what the EMTALA law was designed to prevent. And the court, keep in mind, these are judges, right? They don't know anything about EMS, but this is a pretty spot on analysis. They say if the crew of an ambulance fears refusal because they can't provide financial responsibility guarantees to a hospital, they may well decide to approach under the cover of silence. We're not even going to tell you we're coming. Surprise, we're here, right? And the court realizes that that's not good healthcare policy either. So we can't be required to provide any assurances of financial responsibility as a condition of a hospital accepting the patient. Okay, so those are three of the more noteworthy EMTALA cases that have EMS relevance. So now, as promised, let me talk about collaborative informed decision-making on transport destinations. So we call this CID, collaborative informed decision-making. Now, folks, we know as EMS practitioners that patients can accept care and treatment, they can refuse care and treatment, they can accept transport, they can refuse transport. They may do some or all. They may want some treatment, but not all. They may want treatment, but not transport. They may want transport, but not treatment, right? So the point here is that a competent patient or their legal decision maker has the right to make those decisions as long as they understand the risks and consequences. And it's our job to obtain that informed decision making. Now, folks, where we're going to take the patient is itself also a clinical decision that a patient has a right to be heard on and can direct us to do something otherwise, okay? And we'll do some examples here, all right? So, well, let's just go into the examples. You assess a 53-year-old male patient and you call a STEMI, okay? You prepare to transport the patient to an accredited STEMI center, which let's say is 18 miles away, and you're following your STEMI protocols and the whole bit. The patient instead says he wants to go to a local community hospital, non-STEMI center. It's 5 miles away, right? That's my hospital. It's where my doctor is. That's where I was born. That's where I go, right? Now, most of our systems have protocols that deal with these specialty facilities, trauma, stroke, peds, STEMI, whatever, okay? Now, as with any other treatment decision, right? If I had a patient who really needed a hospital and was refusing transport, we'd try to talk them into it, right? Why is this decision any different? Going to a hospital that's not equipped to treat their condition is a bad clinical decision. So the response for the EMS crew shouldn't be, okay, yep, take you wherever you want to go. Sir, hey, we'll take you there, but, you know, assuming the patient's competent, if not, we talk to their legally responsible decision maker. That's what we mean by RD, by the way, responsible decision maker, has to be told of the risks of that decision, okay? So, and your narrative on your PCR should reflect this, that you told the patient of the benefits of going to that specialty facility and the risks of going to an inappropriate or non-accredited facility, okay? So your documentation, you know, this is an example. We informed the patient that we recommended he be transported to University Hospital. And we told him it was a specialty facility specifically approved to treat his type of condition. We told the patient that the risks of going to Podunk Community Hospital include delays in obtaining necessary care that could be harmful to his condition. The patient indicated that he understood our recommendations and that the risks of his decision, and clearly directed us to take him to Podunk Community Hospital. All right. So here we are telling the patient we think their decision to go to a non-accredited center is a bad idea. Going to an accredited center is a good idea, and why, and the patient still chose to make that decision, but now it's an informed decision. They know that there's risks to that, and they are voluntarily agreeing to those risks and asking us to do that. All right, before I do the next scenario, let me do a quick question here. Can a hospital be on, well, Larry, do you want to jump in and set the table for this one? You want me to just read it?
No, I'll go ahead and do it, Doug. So in our area, we have, you know, a bunch of hospitals that are close together. And so one of the local hospitals, you know, they like to go on selective diversionary status, where they're a trauma center, an OB center, and they have a contracted facility with like a prison. So they'll go on diversion to everything except trauma, OB, in the contracted facility. And sometimes when they go on diversion, obviously the other hospitals have the overcapacity because of that. So that's to raise some questions whether or not, how can that hospital be on selected diversion and everybody else has to go over to the other hospitals? And then there's a monopoly effect too, because now hospital B gets overwhelmed and they might have to take diversion, but they don't want to go on diversion at the same time that hospital A is on diversion. So that's where we're at.
Yeah, it's a good question, Larry. Thanks for that. My opinion is no, a hospital can't do selective diversion, but they can do limited resource-based diversion. Let me explain the difference. Because the definition of diversionary status, remember, is hospital lacks staff or facilities, right? So let's say that their CT scanner is down and I'm bringing in a head trauma patient. Look, that may not be the best place for them to go, depending on the patient that I'm bringing in. But if they have a bed available and they have ER staff available, they can't declare diversionary status. So the hospital, if there are certain resources it lacks, and you want to bring a patient who needs that particular resource, yeah, I think it would be within the law to issue a diversionary instruction for that particular type of patient, but not just because we want to keep capacity for our contracted, facilities and, just the certain types of care that we want, So no, that scenario, I don't think complies with EMTALA. But I think if
Yeah,
it's,
that's what I was thinking, because the CT scanners, they do go down, and that's would be a perfectly acceptable reason to divert a trauma. But you know, just being the area that we're in, the next closest hospital is, you know, 15 minutes away. So
yeah.
and I think related to this, we did have a hand up too that I'm seeing. Danny Hughes might want to chime in on this as well, if you have a minute, Doug.
Of course. Danny, go ahead.
Well, this is pretty much for Matt and Larry. I was wondering, is it still the same thing that if both hospitals go on diversion, you both open back up?
That's
Doug, how
correct.
about we pitch that to you?
Well, I can't speak to what the local policy, you know, the hospital policies are, but I know a lot of systems say that that is the case. A lot of EMS systems have policies that say now everybody's off, right? But remember, folks, I think regardless of these policies, always remember that a diversionary order is a request, right? And as we saw in the Arrington case and in the Morales case, EMS has the continuing responsibility to get the patient to the right place. And if you're just not buying what the hospital's selling, they're, you know, divert. Well, are you on diversionary status? Well, we're kind of busy. I'm sorry, are you on diversionary status, right? So we have that sort of continuing option, right, to take the patient where we think is best. We should take what the hospital says as one particular input in that decision making. But even if they all say they're on diversionary status, remember, physical presence at the hospital triggers the EMTALA obligation. And, you know, we've heard stories, folks, of, you know, a nurse or a doc coming out. We told you not to come here. You know, I'm going to report you to the EMS office. And I always tell EMS providers to say, great, can I borrow your phone when you're done? Because I'm going to call the federal government and dime your ass out for violating EMTALA, because that's a federal law that says once we're here, you take them, right? So I don't know. That's my answer to that. But does that address your question, or do you want to follow up on that at all?
No, Doug, thank you very much. You made my point.
Sure. Yeah, my pleasure. Okay. Let's do the second scenario here, that if you're transporting a patient with a potentially unstable angina to the closest ED, let's say it's ABC Hospital, and during the transport, you contact them, give them a report, and the ED says they have no beds, no staff available for any more patients, and we are on diversionary status. All right. So this is a clear following the regulation. We are truly out of capacity. We are on diversionary status. Now, you tell the patient that. Let's assume your patient is competent. That, hey, we were going to take you to ABC Hospital, but they just told us they don't have any beds or people available, so we're going to go to XYZ Medical Center. Patient says, I don't care what they tell you. ABC Hospital is where my doctor is. That's where I've gone my whole life. You're taking me to ABC Hospital. I think most EMS systems would probably honor the patient's wish in that case. And it is true, as we've talked about, that the hospital has to accept the patient, you know, if we disregard that diversionary order and show up there physically. But it doesn't mean it's the clinically best choice, right? Because this hospital truly does not have the capacity. This patient may need more immediate attention and may not get it, okay? So here our obligation is to make sure the patient understands the risk of going to a facility that may not be able to care for them as promptly as they need it. Here's an example of what a narrative might look like. We inform the patient that ABC's ER was full and was experiencing significant delays, and that they directed us to XYZ Medical Center. Patient insisted on being taken to ABC anyway. We inform patient that treatment delays at ABC Hospital could be dangerous in his current condition, right? Okay, so that's just a couple of scenarios, but the idea here, folks, is this idea of collaborative, informed decision making. I mean, where we take a patient is just as clinically based of a decision as accepting or refusing treatment, accepting or refusing transport, right? Where do we go? And let me just talk about one other thing. It's a little unscripted here off the slides, and that is that, you know, these issues persist, right? we keep incurring emergency department bed delays, why do we keep taking everybody to emergency departments? I mean, EMS protocols and medical direction have gotten pretty good that we can fairly safely distinguish between patients who need an ER and patients who don't, right? The statistics, the data tell us that an overwhelming percentage of patients who call 911 don't truly need emergency departments, right? So we've got, I'm sorry, was there a question? Okay. So we've got protocols. We know how to handle refusals. Why don't we work with our system medical directors to implement new alternatives and modalities, right? Why aren't we doing more telehealth? I mean, CMS implemented a rule during the pandemic. We'll pay for it, right? EMS can be a telehealth origination entity. We can be in the person's living room, set up the telehealth consult with the physician or the nurse practitioner or the PA. They get to bill for the telehealth, but we can share that revenue because we originated it, right? So there are models that we can economically, keep patients from unnecessarily going to emergency departments and tying up our ambulances. And folks, even if we don't get shared revenue out of that telehealth consult, in many systems, we've already talked about how expensive deployment is. If I can reduce the number of unit hours that my ambulances are down by waiting in ERs, that's going to save my EMS system a boatload of money, right? In deployment and overtime and staff costs and all those other things. So even if I'm not generating third-party revenue from doing those things, if I can practice safe, clinically appropriate ER avoidance, that's going to pay dividends in my EMS system. So the other thing is alternative destinations, right? During the pandemic, Medicare is paying to transport patients. I mean, normally they only pay to take a patient from a scene to a hospital, right? So we can explore arrangements with clinics and urgent care centers. Now, they may be just as backed up as ERs, but psych patients going directly to an outpatient psych facility, for example, other treatment settings, substance abuse, whatever it might be, where treatment is more appropriate than an acute care hospital emergency department, right? So we should be exploring the use of alternative destinations. We should be exploring the use of telehealth in the field. We should be exploring provider-initiated non-transport protocols, right? Not just patient refusals, but when we say, you don't need a hospital, right? Where is it written on the stone tablets handed down from on high that every damn person who calls for an ambulance has to get a ride to a hospital? And that's why payers look at us like all we are is a transport. If they paid us for patient interactions, whether there's a transport or not, we'd be looked at as the healthcare providers we are and not just the transport commodity that moves the patient from point A to point B. Boy, am I on a little soapbox here. I got an amen. So I guess at least I have one person that agrees with that. So thank you. Okay, let me, but really, I think folks, we, as much as EMS tends to lay this dead dog on the hospital's doorstep, right? The hospitals are making us do these things. The hospitals are not taking these patients when they should. They're holding us, why do we keep throwing sausage at the sausage grinder, right? And I just think we're advanced clinically now. When I started in EMS, it was a local family physician who volunteered to be the medical director, didn't necessarily know anything about EMS, right? Now we've got more sophisticated medical control in place. We've got well-developed protocols. We've got good clinical data that supports this decision-making. And we know how to monitor the data going forward. If any of these policies don't work, we can tweak them, okay? But, I'm a lawyer, folks, and I was an EMS provider well before that. And I see, comments that we were told it was a liability issue and that sort of thing. Right, because if the regs and the policies and the protocols that everybody writes simply say transport all patients, well, yeah, that's what we got to do. Why don't we go back a step to those policies, protocols, medical control, and revisit all those things and say, wait a second, why do we do that, right? Well, it's what we've always done. The most dangerous phrase in the English language is this is the way we've always done it. So we can reduce the liability if our protocols, speak to that, right? These are medically validated, clinically approved protocols that say, oh, you got this, this, and this. You don't need to go to a hospital, okay? And we're not going to take you because that's not what we're here for. And that's when we can start to attack this problem. And okay, I'm going to get off the soapbox because some of these questions and answers in the slide deck are going to get me back on other soapboxes. But let's move on here a little bit, and then please keep your questions coming. We are going to have plenty of time for Q&A, but I do want to get into some of these practical questions, things that we do hear a lot or get asked a lot, and speak to some of these. And some of these may just be a bit of a recap from some of the principles we've already talked about here. This one I hope is already clear based on stuff we've already covered. When does the patient become the hospital's responsibility? And the answer is when they arrive on hospital property, not the ER, but hospital property. And we have already defined that rather expansive definition of hospital property that incorporates that 250-yard rule. And we saw, and I'll just repeat this quote, hospitals that deliberately delay moving a patient from an EMS stretcher to an ER bed don't delay their EMTALA obligations. So one of the most common things we hear is reports that hospital staff tell EMS that you've got to keep the patient on your stretcher and they're yours until we accept them. Legally, acceptance happened when the patient got onto the hospital's property, okay? So that patient is clearly, without a doubt, there's lots of gray areas in the law, folks. This ain't one of them, all right? Clearly, when the patient arrives on hospital property, the patient is the legal responsibility of the hospital. Okay. If we're in the hospital with the patient still on our gurney, are we legally responsible for the patient? No, the legal responsibility for the patient on the hospital property rests with the hospital. And folks, this is true whether they're on your gurney, whether they're in a waiting room chair, on a folding camping cot on the floor, whether they're, whether they're out front smoking the cigarette while they're waiting, wherever they are on the hospital's property, no matter who owns the chair, the cot, the bed, or whatever it is that they're on, it is the hospital's patient. So this fiction that hospitals, some people in hospitals have created, that your stretcher, your patient, simply is not true, okay? Your property, your patient, right? We're in your building, we're on your hospital property. It's crystal clear that that patient belongs to the hospital. This one we've already addressed, so this is kind of a review as well. Can the hospital require the EMS crew to remain with the patient? Well, we already saw the answer to this. They can ask EMS staff to remain with the patient. Whether the EMS crew does remain with the patient is voluntary under federal law. And folks, here is where it's up to the EMS agency's policies and procedures and practices. And, I told you earlier about this conversation I was having with one of our state EMS directors earlier today about this issue. And, there's a concern that we've done this for so long, right? Meaning that EMS has sort of begrudgingly accepted this status quo that we wait until the hospital tells us we can go, right? That it's almost become a de facto standard in our profession or in our industry. But, where there's a federal statute and regulation that says otherwise, it's very clear. And I think our industry, just because we all got into this to take care of people, and if we get there and the nurse says we can't take care of them yet, our natural instinct is to want to take care of them because that's what we do. We take care of people. But we have been really on a tear here the last, year, making sure that EMS knows that that decision is voluntary. Now, folks, let's just take a hypothetical here. You got a serious patient, right? Patient having a possible MI, possible stroke, possible something bad. None of us are saying here, folks, and I think you know this by now. Well, I heard this EMS lawyer say we don't have a legal responsibility to stay with the patient, so we are out of here. Their vitals are all, in the toilet, but we're leaving. I could argue, if I was defending you in a malpractice case, the legal responsibility is clearly assigned to a hospital once we arrive at hospital property. I can make that argument. Now, you ever hear this saying that when you go to court, you put your fate in the hands of 12 people who weren't smart enough to get out of jury duty? Well, that's an exaggeration. Juries usually get it right. But look, what is a jury going to say if a case like that goes to a jury? This guy was really circling the drain and these paramedics or EMTs just left when the nurses said we were too, right? I don't know how that would play. And look, the idea here would be that I would try to get that case thrown out before it even got to a jury on the basis of EMTALA imposing that clear legal duty on the hospital. But I can't guarantee what a judge is going to rule if I make that motion to dismiss, right? So if a case like that sees the light of day inside of a courtroom and a jury gets to decide that, look, I don't want any of you to be that test case. Doug Wolfberg said we can leave. We are caregivers first. And if we do the right thing for the patient, the law is going to do the right thing for us. Okay. But now let's think through this, though. When a hospital is making us wait, I would like to think, and this is not always true, I get this, but the really critical ones who are bleeding, who are screaming, who have bones sticking out of their skin, who's clutching their chest and they're turning blue, the hospital they're going to take them, right? By and large, statistically, folks, the one they're parking us with, the ones that they're making us wait on, are the ones who are not acute, who could wait in a hospital without anybody sitting there watching them, right? Their waiting rooms are full of people like that who were driven in by a layperson sitting with them, right? They're not going to die because you're not sitting right by their side the whole time you're waiting for the nurse or waiting for the doctor. My point is, with our medical directors, we can develop the right kinds of protocols to identify the patients who need us to stay versus the ones who don't need us to stay. And I can assure you, folks, that the research, the data, the evidence show that the vast majority of patients don't need us to stay clinically, okay? So let's make those decisions on good clinical sound evidence. But look, if we left a patient who needed care and they had an adverse outcome, everybody's going to get sued in that lawsuit. I'll make the argument, I'll defend you and say the hospital had that legal duty as a matter of law. But again, juries can do funny things. Okay, that little diatribe brought a few questions. So let me take a couple of these. Question for in-hospital EMS, tech in the ER, had a patient that had gone to a lower level to smoke and had gone unresponsive just outside the hospital front doors. The ER was advised by our PD, in which we were told to take a bed to get the patient, and a rapid response team was called. Once we got the patient to the ER, we were told that since the patient was a patient on a floor already, the patient had to go to this floor because of EMTALA. Sort of, kind of, yes, sort of, kind of, no. All right. If the patient, for whatever reason, is an admitted patient and goes outside and has an emergency, the hospital has to respond. They have to act. They should see that patient in the emergency department or get them back up to the floor as long as they're getting immediate care. Under EMTALA, it really doesn't matter where they get that care inside the hospital, because it is true that once a patient is admitted, the the hospital has concluded its EMTALA obligations. Okay, so it may get sued for malpractice if it delays the care in that case, but they probably could not be held liable under EMTALA because admission ends the hospital's EMTALA obligations. So it's a good question. Next question, is it appropriate for EMS to continue to treat the patient with IV drugs on hospital property during an extended wait time if the patient was in extreme pain? I believe yes. If it's, let's assume it's an ALS crew, and let's assume that those analgesics are within their formulary and scope of practice, I think the crew has a right and a duty, if they're staying with the patient, to do those things that are necessary to treat the patient. I just don't think we should see some magic force field that once we go in the hospital, we have to check our credentials at the door, right? If the hospital's not going to treat them and they need treatment, we should. But, you know, as I cautioned earlier, we shouldn't do something that's beyond our scope of practice. Whatever the meds are that are in our drug box, I mean, you can use, document it, the whole 9 yards. If they hand you meds or you go and open up their drug cabinet and start giving things that are beyond our standard of practice, then I think that would be a problem. There's a comment that says not for our hospitals. I'm not sure what that was responding to. So if the person who asked that wanted to add anything or clarify, feel free to do that. Does anybody?
It was based on the whole critical thing. I've had nurses hold us for 20, 30, 40 minutes on critical patients because they just didn't want to take care of the patients at the time.
Yeah, thank you for clarifying that. So as I said, I know that I don't want to overgeneralize because I know there are cases where you truly do have critical patients who are being, you know, parked. But I think statistically, and I don't have any data to show this, but I think it's more likely that the ones who get parked for extended periods of time, I'm talking about these hours long offload delays, are probably already not critical, right? Or not emergent. But certainly there are exceptions, and, you know, squeaky wheels and getting the grease and all that kind of stuff. You know, we got to let, you know, the hospitals know that if we think a patient is crashing. A couple of months ago, I got retained as an expert witness in a case down in Florida where the crew delivered the patient to the hospital, and then the patient went south and the crew was named in a lawsuit. And, you know, we'll see where it goes. But, you know, obviously our position is that the legal responsibility, the duty of care fell with the hospital in those cases. Okay. Let's see. I think we covered the can they require EMS to stay. Let me talk about this one for a second. One unresolved question. It's not addressed by EMTALA directly. It's not addressed under these rules and regs that we've covered. Whether a state EMS office or a local EMS regulatory agency, like a EMS council or something, can pass or adopt a policy that requires EMS personnel to stay in the hospital until released, right? So we have been seeing this come up a lot in, well, particularly in California, where some local EMS regulatory bodies and their county medical director, EMS medical director, put out these policies that say, you know, for patient handoff and coordination of care, when crews arrive in a hospital, they must remain with the patient until released by a hospital, and you can't leave till you get the signature, and, you know, the whole 9 yards. So we were asked on behalf of one of our clients in that state to respond to that policy. And our position was pretty clear that, number one, a local or state law or regulation or policy that conflicts with federal law is superseded, right? It's called preemption. Federal law oversees or preempts state law or local law where those things are inconsistent. Federal law clearly says the legal duty belongs with the patient. So a county can't pass a policy that says, no, we're keeping that legal duty with the EMS crew, right? Because federal law very clearly says that's not the case. But the other thing we noticed when we dug down on some of these policies, and I again, this is not anti-hospital, but in a lot of cases, EMS medical directors work at hospitals, right? They practice in ERs. So in some cases, they have a built-in conflict of interest when they put these policies together that are really benefiting hospitals. What do these policies say? EMS must provide free labor to the hospital, right? If they're the hospital's patient when we arrive on hospital property, which we know they are, if local decision makers are trying to pass policies that make us provide care to hospital patients inside the hospital, these policies are nothing more than saying the hospital staffing shortage now falls on EMS. You are a forced subsidy to the hospital staff. And where medical directors and EMS regulatory agencies are putting policies like this together with clear conflicts of interest with these hospitals, it's a big problem. So honestly, you know, folks, EMS councils and EMS regulatory bodies are supposed to look out for the good of the EMS system. There's plenty of advocates that advocate for hospitals. That's not what an EMS agency should be doing. Okay, there I am preaching again. Another question that from the chat: if the emergency happens on hospital grounds, should the hospital have a response team? Kind of, yeah. The CMS rules don't use that phrase response team, but they do make it clear that the hospital has to have a policy in place to get that patient from wherever that on-campus emergency occurs to that emergency department so that medical screening examination could be done. The CMS guidelines on that also say that calling 911 should not be their primary solution to that problem, right? So that does mean the hospital should have some internal process. If you want to call that a response team, that's as good of a term as any I could come up with, that they should have some mechanism to, you know, in an extreme case, okay, call 911, but by and large, on-campus emergencies should be dealt with by the hospital. They should have policies, and they should make sure the people in these other locations around the hospital's campus know and are trained. What if it is the clerk at the coffee shop? Okay, there should be something other than unbridled panic. They should have at least some basic training. Here's the number you call. Here's what you say. Here's what you do. Okay, we don't expect them to do medical screening examinations and give us a differential diagnosis from behind the coffee shop counter, but we do have to ensure that that hospital has a plan and a policy to get those on-campus emergencies into that emergency department. So it's a good question. Okay, can we leave the hospital with the patient still on our ambulance stretcher in the hallway? Well, this question comes up. I mean, yeah, you can.
Excuse me.
Yeah.
I apologize. I'm driving. I'm not on the computer. I have a question to that last comment.
Yeah.
In the case of physician office buildings or other medical suites on campus of a hospital, how does that come into play as far as determining hospital property? Professional buildings, medical office areas.
Yeah. So, right. Those other, I wish I could give you a really straight answer to that, but Medicare has a policy or a rule or a designation called provider-based, right? So hospitals can elect certain parts of their campus be provider-based or non-provider-based, right? So if it's provider-based election, it's clearly considered hospital property if it's on that campus. But CMS has said that those other areas, let's say there's a professional office building, medical office building on the hospital's campus. So if a patient has an emergency at that on-campus location that's not part of the main hospital, use the medical office building example, the hospital doesn't have the EMTALA obligation to do the medical screening examination and provide the stabilizing treatment there in that doctor's office in the medical arts building. But that does come under the hospital's requirement that they have some procedure in place to get those patients over to their ER on the hospital's, because they're on the hospital property already, so that medical screening examination can be done. So it's a bit of a hybrid. It doesn't automatically impose the EMTALA obligation on that physician's office, but the hospital has the responsibility to have some kind of procedure in place that that patient can be brought over to the ER for that medical screening exam. Does that help?
Absolutely. Thank you very much.
Yep, of course. Okay, another question that came up in the chat, and after I do this one, folks, as I said, we're gonna have time for Q&A, and I would welcome folks unmuting and just asking questions verbally as well. Maybe Larry or Matt or somebody can moderate that with the hand raising feature. But let me read this next one. If the EMS crew continues to treat the patient in the ED during a prolonged wait for a bed, and the EMS crew administers an inappropriate drug with a negative outcome, or an intubation attempt results in an unidentified esophageal intubation or some other omission of treatment, who is responsible? The EMS crew or the hospital? Yes, is the answer. Certainly, if the EMS crew continues care inside the hospital, we've already established that that is voluntary. But if they do it, they can't do it negligently. Okay, so even a voluntary undertaking has to be done with clinical proficiency, right? So just like a misintubation out in the field, if we don't verify tube placement, and if we don't do the steps that we need to assure tracheal as opposed to esophageal intubation, all of that still applies. And certainly the ambulance crew is going to be named in a suit where there's a bad outcome, especially where they were negligent inside the hospital. So let me put it another way. The fact that the law imposes the legal duty on the hospital doesn't mean that you're relieved of a duty if you decide to act in that capacity. More than one party can have a legal duty, right? If a guy in a car gets waffled at an intersection because the other car didn't stop at a red light, well, he had a duty to stop at a red light, but that doesn't give the doctor who treats the patient a license to be negligent. They have a duty to provide good care, right? So there are multiple duties that apply in any given situation. And I think the crew would definitely be on the hook for negligence inside the hospital. And I think the hospital would too, if they failed to promptly take control or custody of that patient. They put the patient in a situation where they became a victim of negligence when they should have accepted responsibility sooner. So it's a great question. It's a heck of a scenario. I'm not aware of a specific case. Perhaps the one that I'm retained on down in Florida will be one of the first if it goes to a trial or anything. Most of these cases settle, but it's a great question. Okay, let me take the next question here on the screen. Can we leave the hospital with the patient still on our stretcher? Yes, but the legal responsibility for a patient in a hospital, I've said it 100 times, clearly rests with the facility. But if now, let's say, we're leaving, we got extra stretchers, we don't need this one, we're out of here, right? Well, if somebody in the hospital isn't familiar with how that works and patient tips over, or the stretcher collapses or whatever, yeah, there could be tort liability on the part of the ambulance service for that. So if your solution is to leave the patient on your stretcher, which I think legally you could do, if you had another stretcher to go back in service, I think it behooves you to make sure somebody at the hospital knows that you're doing that and knows how to work the stretcher, that you're leaving the patient on. Can the EMS crew leave the patient with someone lesser qualified? So I have to tell you, this higher and lower level of care question is one of the ones that made me go to law school, because I started in a volunteer small town ambulance service, and I think many of you probably have met similar people, that the station house lawyers, right? You can't do that. That's it. And I even when I was a kid starting out as a volunteer, I knew that a lot of that stuff I heard in the station was utter bullshit, right? So maybe that planted, someday I'm going to go to law school and tell these jackwagons that they're wrong. But so this old sort of, and I apologize for my colorful language, folks, but remember I came from EMS before I went to law school. There's this age-old sort of conventional wisdom that you can only hand off a patient of someone, to somebody with equal or higher credentials than you. If that was true, folks, doctors' living rooms at home would be crammed with patients because they could never hand them off to anybody, right? There comes a time when a person no longer needs care, right? And there also is a time when we've identified that a person doesn't need this level of care. They're perfectly good with that level of care, right? So if we've assessed a patient and we've determined their low acuity, well, number one, let's hopefully not transport them. And we talked or do telehealth or take them to an alternative destination. But if we do take them to an emergency department and we've got some good clinical guidance in place that helps us determine which patients are low acuity, I could escort them into the waiting room and leave them with nobody and be well within my legal rights to do that and very low risk of liability, because clinically I know this is a patient who is very, very likely to not have any adverse outcome whatsoever by getting off our stretcher and going and sitting in the waiting room. Okay. So, yeah, it doesn't have to be the medic can only hand off to the nurse, physically to the nurse, and the EMT can only hand off to a medic or above, right? Sorry, I've got a patient here whose vitals are, 120 over 80, pulse is 68, respirations are 12. Patient has no complaints of pain or discomfort. Whatever, these low acuity patients, hey, we're going to let you know that we are leaving, and here's our even verbal report, because I don't necessarily have my full PCR done, but here's what we're doing. Here's where the patient's going to be. Here's what our assessment showed, and patient's fine. We're out of here, right? But again, from a clinical and a human perspective, if I've got a patient who needs the care, that's not the right answer to walk away just because a lawyer said you could, right? So these should be clinically driven decisions. Question? No. Okay. If we know there are extended wait times at a particular hospital ED, can we take the patient to a different facility? Absolutely, as long as that does not violate any applicable EMS protocols or the express wishes of the patient or the patient's legally responsible decision maker. And as I talked about earlier, the crew should have collaborative, informed decision-making discussions with the patient, especially when they insist on going to a facility that's bad for their health, excessively long waits or not accredited or something like that. That's when, we have a duty to come to a good, collaboratively formed, informed decision about the destination with the patient. And if I have a patient who is not capable of making informed decisions and no other decision maker is present, and then it is within the EMS standard of care for the crew to make that determination in conjunction with our clinical protocols.
Hey, Doug.
Yeah.
This is Matt. Just on that. So what if an ambulance pulls into the driveway of a hospital, say roughly 20 miles away, and sees how full it is, and says, we're going to the other hospital.
So they've already arrived at the hospital's property?
They're physically on the property and say, we're not doing this.
Yeah, so assuming that the ambulance is not owned and operated by the hospital, they're free to say, oh, this, too long of a wait at this restaurant, let's go eat somewhere else. Okay. Yeah, they're absolutely free to say that. It is not an EMTALA violation for the ambulance because EMTALA doesn't apply to the ambulance. Maybe a problem for the hospital, but it's not for the ambulance.
Okay, that would stink for the hospital because they didn't have anything to do with it, but
Yeah, and honestly, I can't see CMS coming down and slapping the hospital with a penalty if they didn't even know the ambulance got close enough to eyeball, the situation and then left. No contact was made, no request for treatment was made. I don't see that being a huge risk to the hospital. But if we get in and check in, and then we say, okay, well, we're leaving, we can. It's not, again, it's not on us, but in that case, that could be a bigger problem for the hospital. Hey, let me ask Matt and Larry, the hosts here, do you want to take another, should we take another short break and then come back and do the rest of the Q&A?
sure, if you need, yeah, if you're ready for a break, we could take a break.
Yeah, I just want to make sure people's heads aren't spinning here with all this barrage of information. So my time says 8:16. We'll call it 8:15. Let's just do, you want to just do a quick 5 minutes, recalibrate, and then, okay. So we'll see everybody in 5 minutes. Okay, folks, give everybody a second here to get back. While we do that, I will read a question that came up on the chat here. On the note of lesser qualified people, I've had it said that medics are only allowed to give report to an RN, absolutely not to give report to an LPN or a hospital-based medic. I know that's sort of been, like I said, I think a lot of the conventional wisdom or the way that we've approached things, but there's not really a legal requirement, right, that if folks could mute their mics, I'd appreciate that. Thank you. But no, I mean, again, if I have a patient I'm a BLS crew and they're severe chest pain, shortness of breath, I'm going to want a nurse or a physician, right? But a stable patient, non-acute, medic says the only person who's available is the clerk at the desk. Here's a quick notes on what we're doing here and here where we're leaving them, and I wouldn't have any problem defending that, honestly, as a lawyer. So, okay. What if the hospital asks the EMS crew to administer treatment while waiting in the emergency department? We've kind of covered this, unless prohibited, and most states wouldn't prohibit that. The EMS crew may administer treatment inside the hospital, but it should be within their scope of practice. If the hospital asks the staff to provide care outside the scope of practice or even beyond their level of comfort, can the EMS staff refuse? Yes. In no situation, really ever, should an EMS provider be furnishing care beyond their scope of practice or perform a procedure or administer a treatment or a medication that they're just not familiar with. That's just an invitation to a bad outcome and to legal liability in either case. And this is true even if we're directed to do so. And remember, the CMS guidance makes it clear that if the hospital's solution is to ask the EMS crew to remain with the patient for a period of time, excuse me, the hospital needs to assess whether the EMS crew has the capacity or is capable of appropriately monitoring the individual's condition. I've got a patient with a possible MI. In other words, a hospital shouldn't be asking a BLS crew with no cardiac monitor to stay with that patient for an extended period of time, right? Part of the hospital's duty to do that medical screening examination, if they're going to ask, the EMS crew to wait with that patient, they've got to make sure the EMS crew has the right level of capability to adequately monitor and care for that patient during that time that they're asking them to keep the custody of that patient. Can our ambulance service set limits on how long we will wait before we leave? Yes, because this whole thing is voluntary on the part of the ambulance service, whether or not you remain with the patient. It's also up to the ambulance service to determine how long. We have clients that say, we'll give you 15 minutes. After that, we're out of here, right? But I think it's fine for the ambulance service to adopt a policy, perhaps put a clear written policy together or part of a protocol, as long as the patient doesn't have this, or this, right? They're not actively doing CPR, or they're not on high flow oxygen, or we don't have an IV, with pain meds running or something. We're going to leave within this time frame, so the hospital has clear notice that is your policy. Do we have to leave a completed PCR with the hospital before we're free to go? Not usually. Very few states, and I apologize, I didn't have a chance to look up Ohio's before I left. One of you may know better than me. Feel free to put that in the chat. But very few states, if any, require the completed PCR before you leave the hospital. Most give a period of time that the final PCR has to be completed. But, check your system's local policies on this, and if necessary, change it. Because like I said, if a local EMS agency puts a rule in place that, you can't leave until you have the PCR completed, or you can't leave till the nurse signs off, those are not consistent with federal law, and we shouldn't be hampering our systems that way. But make sure that all information necessary to the patient's transition of care, their continuum of care, is communicated to the hospital before you leave, even if that's a verbal report. Okay. You know, a lot of systems have, you know, the quick sheets, the half sheets where just basic info. We may have field notes. It could be the verbal report. 60-year-old male, he's had past history of MI, had some chest pains earlier today. Right now he's stable. He's got no pain, right? Even that quick verbal report. But then we want to document on our PCR that we provided that verbal report, and if possible, who we provided it to. Okay. And a question came up in the chat: how do you leave a patient without giving at least a verbal report? As I said, I mean, I think whether it's the full PCR, field notes, or a verbal report, you do have to communicate the necessary information for somebody to assume the care of the patient, right? If you pushed a drug, they need to know what you pushed and how much and when. You know, whatever that important information would be, that has to be communicated. But since the last question in the chat used the word abandonment, let me raise that issue, because we have also heard it said that if an ambulance crew leaves before being excused or, you know, released by the hospital, that they're going to report them for abandonment. Folks, this is interesting because in EMS, not a lot of us have taken the time to actually look at what the legal definition of abandonment is. And it's different than I think a lot of folks think. And honestly, till I went to law school, I just always thought abandonment was we left, right? Well, abandonment is the withdrawal, and actually almost every state's legal definition of abandonment applies to physicians. There really aren't specific abandonment case law on the EMS side, but let's just assume for sake of argument that abandonment does apply to EMS as a principle. And I wouldn't argue otherwise. I mean, we shouldn't abandon patients, but what is abandonment? It's the withdrawal of medical care without making arrangements for substitute or other care, right? So if I walk up to a patient at the intersection of 3rd and Main and they were just hit by a car and there are multiple trauma, and I walk up and go, oh man, multi-systems trauma, there's more than I want to deal with. Sorry, you know, good luck, we're out. Yeah, you got an abandonment problem. But it cannot, as a matter of law, in my opinion, be patient abandonment when we leave a hospital where we've taken the patient, right? When a hospital has an affirmative legal duty under federal law to take that patient, and we know it's the hospital's patient when we arrive on their property, I don't understand as a matter of law how it could possibly constitute abandonment. We didn't leave the patient on the corner of 3rd and Main. We left them in a licensed healthcare facility that had a duty of care to the patient, right? Now, folks, there may be cases that will be brought. Perhaps this case I mentioned earlier in Florida will give us some guidance on this. But, you know, my view strongly is that it can't be patient abandonment. As long as the hospital knows we're there, you know, we've informed them, we've given them the information, and we leave, I'll take that case. And if somebody tries to claim it's abandonment, it simply does not meet the legal definition of that term. By the way, that call that I was on earlier today with an state EMS director, there were actually a couple of state EMS directors on it. I won't tell you which state. Wasn't Ohio, so I'm not, and these aren't binding statements, but I asked them, you know, if a complaint came to your office alleging abandonment, if an EMS crew left an ER, you know, after delivering the patient, would you, you know, enforce it or bring charges against the EMS providers in that case? And they all said no, right? That they agree that is not legal abandonment. So, and one said, I wish somebody would make such a complaint in my state because that would give me an opportunity to tell the hospitals what the law really is on this. So, so I thought that was interesting. But of course, those are other states. That's not binding on anybody. But I just thought it was interesting insight. Okay. Can we leave before we obtain a handoff of care signature? Yeah, in most cases, yes. It's typically not a legal requirement to get a handoff signature as a condition of being able to leave. But again, make sure you know your specific rules on this, but also keep in mind, we have seen some local EMS policies be implemented with conflicts of interest signed off by medical directors who work at these hospitals, right? You can't leave till we sign. Well, federal law doesn't require that. Most state law doesn't require that, right? Getting handoff signatures is usually just kind of a practice that we follow. It's a good practice. I would get signatures whenever we can, but it's not a legal requirement in most cases. And it's also not a requirement to be able to leave, right? So, but that's something, again, check local policy on that. But in most cases, the answer is no. All right. What if a patient calls 911 from a hospital ED waiting room? Well, generally an EMS agency has a legal obligation to respond to a 911 call, no matter where it arises. But what happens when you get there, right? If you're not a hospital-owned ambulance, right? Because remember, the rules are different for hospital-owned ambulances. If you're not a hospital-owned ambulance, you can leave the facility and transport that patient to a different hospital. It's not your EMTALA problem. Now, I would certainly let that hospital know that you've been called, you responded, you arrived, here's what we found. They say they've been waiting in chairs for 3 hours. They don't feel well. They want to go to the hospital across town. And look, if the hospital says, okay, we'll get to them right away, maybe that will satisfy the patient. But if the patient says, I want to leave, I want to go somewhere else, you're entirely free to do that. And it is not an EMTALA problem for the ambulance, but it sure may be for the hospital. Here's another sort of well, let me take a question that just came on the chat. What is your opinion on EMS providers obtaining a private malpractice insurance policy on your own away from your employer, just in case legal issues arise? Yeah, I get asked that question a lot. The answer is it really kind of depends on what assets you may have that you want to protect with insurance. And sadly, a lot of EMS providers chuckle at me when I say that, you know, assets, right? You know, the other side of that coin is individual liability insurance is really not that expensive. If you look at, I think NAEMT has endorsed a plan, and there's other companies out there that do that. And you can, in many cases, add, it's called a personal liability umbrella policy or a PLUP to your either your homeowners or your renters coverage. And it's typically very inexpensive. So my answer is if it gives you the peace of mind and you can afford it, it's worth it. But I will also say I have never once seen a case where an EMS provider was forced to pay part of a settlement or a verdict out of their pocket if it was simple medical malpractice. If you did something intentionally wrong, smack the patient around, right? Or give them oxygen, the whole bottle, right? That kind of stuff insurance is not going to cover, right? So no policy would give you any benefit if you did something like that. But short of that, if we're talking about simple everyday medical malpractice or negligence, I have not encountered a case where providers' own money had to be put on the table. But again, the policies are inexpensive, and if it's peace of mind, I wouldn't begrudge anybody for doing that. Okay, next question. Can the ambulance service employ a handoff coordinator to monitor patients in the hospital? Yes, as long as it's not prohibited by state law, and I don't know of any states that do prohibit that offhand, you can put an employee of your ambulance service in that hospital, right? So instead of tying up each crew, we just brought in 3 patients in the last hour. Our guy or our gal is going to be in charge of our 3 patients until the hospital accepts responsibility. Now, we know those are hospital patients already, right? But some systems have found it better to at least just bite the bullet and pay for this one person instead of tying up the 6 people on those 3 ambulance crews, right? So that has been, you know, and then the crews can return to service. So that's been a solution that we've seen in some systems, you know, but of course it has expense to it. That little inside that staging area could be in the hospital, could be outside, could be the tent, the parking lot, that kind of thing, right? This question, if we're only using a hospital as an LZ to transfer a patient from ground to air, does that hospital have EMTALA obligations? We already answered that one, no, unless a request for examination or treatment is made by or on behalf of the patient.
Hey,
By the way, yeah, go ahead.
What if the heliport's on the roof of the hospital? You have to go through the hospital to get to it.
Same answer. It doesn't matter if it's in the facility or on a separate ground level LZ. The answer is the same. The hospital does not have an obligation to do the medical screening examination unless they are asked to intervene.
Okay, thank you. That came up in another conversation. That's why I asked.
Yeah, of course. No problem. So another thing that was not on the slides here, folks, and that is, can an ambulance service ask a hospital to pay for the cost of its staff for attending to patients inside the hospital? Answer, yes. You can ask. Now, whether the hospital agrees is an entirely different story. But some of you may have read the series that we wrote in EMS1.com called Ambulances Held Hostage. If you haven't, I would suggest you look that up. We talk about that at some length in those articles. We also talk about a law called the anti-kickback statute and how that can become a problem. We're giving free staff services to these hospitals that may also be referral sources, which could be a problem. And it's not hard to calculate the value of the time that you provide to these hospitals, right? So it is not inappropriate at all to ask hospitals to pay those costs and even present them with agreements to do that. And yes, we've drafted sample agreements, and I'll tell you about a publication here in just a second. So let me just do a quick summary of all the didactic stuff that we've covered here. EMTALA applies to hospitals. It doesn't apply to ambulances unless they're hospital owned. But that interaction between EMTALA and EMS is significant. Hospital-owned ambulances are considered hospital property for EMTALA purposes. Non-hospital-owned ambulances trigger EMTALA once they arrive on hospital property. If a non-hospital-owned ambulance calls into the hospital by phone or radio, indicating they're bringing the patient to that hospital, the hospital cannot divert the ambulance unless an EMS protocol says so, or they are on official diversionary status, or the patient makes that informed decision to go somewhere else. Once the ambulance shows up on the hospital's property, even if they were given a diversionary instruction, the hospital's EMTALA obligations to take that patient kick in. A hospital can ask an EMS crew to wait with a patient, but the hospital's EMTALA obligations apply regardless. Okay, a couple of other quick things. Still time for questions. I'm not trying to rush us through here, folks. So after I finish this stuff off here, folks can unmute and ask questions verbally. You can put questions in the chat. I am yours for another 20 minutes. But I do want to invite you all to visit our website, pwwemslaw.com. There are a lot of, there's EMTALA guidance on there. There's some sample forms, informed decision-making forms, that kind of stuff. Hit us up on all the social media channels. Feel free to hit me up on LinkedIn. Happy to accept connection requests. And we post a lot of good stuff on those social media channels. Oh gosh, I thought I had a slide that was going to tell you all about our new publication called the Hospital Bed Delay Survival Toolkit or something along those lines. Our sister organization is called PWW Media. And if you put pwwmedia.com into your browser, you will see the info on that new publication. It is available for pre-order. It'll be out in a few weeks. So that will have a lot of text explanations of a lot of the stuff that we've been talking about, as well as some sample tools that you can use, such as a model agreement to present to the hospital for fair reimbursement of those costs that we discussed. Okay, so that is all the death by PowerPoint. Happy now to take any other questions or discussion on this or anything else that's on your mind in the world of EMS law.
Looks like Tom Young has his hand up.
Go ahead, sir.
All right, I have a couple questions for you. So the first one is in regards to the state of Ohio has put in place the stroke center criteria to kind of follow the same guidelines as trauma triage and taking it to the appropriate level trauma center. And they're kind of following that guidelines as far as strokes go too. With that being said, in a certain hospital system that we have in our area, I have taken strokes to that hospital system, and they have significantly delayed care for one reason or another in a pretty significant 100% black and white stroke. So a lot of the times I make the personal decision that it is best, as long as the patient, is the family or the patient states going to a local hospital. I take the personal route of not going to that stroke center because in the past I've seen patients care delayed significantly at those places, and I know that the other two will at least get them straight over to CT and start TPA and the appropriate treatments. What liability will I have if something happens at those because I'm making that personal decision instead of going to that stroke center if I document the reason why?
Yeah, so that's a great question and very thoughtfully asked. Let me say that I think there's a risk there because, protocols are helpful, they're good, but they're also a roadmap for a plaintiff's lawyer if we deviate from those protocols. That said, you just gave a very earnest, good answer for a rationale for that decision making. Remember, at the end of the day, we're asking juries to weigh in on these questions. I don't think what you just said was unreasonable. Would 12 people in a jury box conclude the same? Or would the plaintiff's attorney hire an expert that says, look, these paramedics may have their own opinions, but clinical protocols are there for a reason. It's the same reason pilots have checklists. We don't deviate or people die, right? And the jury could go, well, that gal or that guy really had a great point, So I think there's risk. Honestly, I think probably more risk than average in that decision. But clinically, I completely understand the basis for making it.
Thank you. And then the next question is, it doesn't have to do with hospitals necessarily, but as I'm sure you've encountered, private ambulance companies can be special. The administrations can be special at times in what they want out of their crews, specifically being run numbers, which equates to money for the company. And the question comes into play, protocol or standing orders versus company policy in getting the run numbers that they want to see versus executing the appropriate protocols in a high call volume crisis situation. Which one are we more obligated to follow?
Well, that's another great question. And, let me first say that, my firm represents a lot of private companies, a lot of public agencies, a lot of nonprofits. We're equal opportunity. And I think that I will say that we've probably represented just as many public and nonprofit companies in false claim cases as we have, maybe more than privates, believe it or not. So I don't think private companies have the market cornered on revenue concerns and revenue considerations. That said, you are absolutely right that, particularly a private company that's a standalone ambulance company, right? Hospitals, if they lose money on one department, they make it up, in ambulatory surgery or something, right? So a standalone ambulance company has one line of business to generate their revenue, and that's ambulance calls, and most payers only pay if we do a transport. So yeah, those pressures are there, but I can tell you that the risks of medically unnecessary transports and then billing for them, medically unnecessary procedures, put a cardiac monitor on everybody so we can bill them ALS, right? We've had cases like that, and they don't end well for the ambulance service. So short-term revenue objectives are simply not worth the long-term risk, whether you're private, public, nonprofit, hospital-based, third service, whatever configuration you are. Eventually those things come out and it doesn't end well. So I don't know if that addresses your question as directly as you'd like. I'm happy to take a follow-up if I didn't answer it satisfactorily.
No, that answered it completely. I appreciate that. I'm sure there's other people in here that had that same question regarding privates as well. And then the final one is we've ran into a situation where an ER doc was highly uncomfortable with airway procedures and asked the EMS crew and myself to perform the RSI in the ER and intubate the patient. We refused because, and I think you covered this, that puts us under a huge amount of personal liability functioning that way in the ER when it's their responsibility. And I'm correct in that understanding, right?
Well, let me ask you a quick question. Is RSI or PAI in your scope of practice?
RSI is in my scope of practice, but it's not currently in my protocol. We do not carry the drugs on the truck to be able to do it. The doctor asked me what dosages of drugs I would need to perform the procedure, and without written rules on how to do it, the state of Ohio does recognize that we can do it as paramedics. I learned it in paramedic school, but there's no doctor that has authorized me to push the drugs.
Well, okay. Another great question. So let me talk about something else that I haven't really touched on, because I didn't want to muddy the waters, but I think this is a good question, and it was, again, thoughtfully asked, so I think folks will understand the answer I'm about to offer here. So most states permit physicians to delegate medical procedures to virtually anybody who the physician believes is qualified and capable of doing that. So I know it sounds a little contrary to what we said about staying within your scope of practice when you're asked to do something inside the hospital, but from your answer, this is within the scope of practice, but perhaps not a specifically precepted or approved skill by your agency medical director. I would want to do a little bit of research on this, but again, in most states, there are general rules of medical practice, usually under the Medical Practice Act that governs physicians, that do permit general delegation to anybody a physician thinks can competently handle a task. If I found evidence of such a law in Ohio, I would probably tell you I think it's a pretty low risk proposition to do that. If you believed you could do it competently, then I don't have a whole lot of heartburn about that. But if it's not a scope of practice skill and you're not permitted by your local medical director to do it, I wouldn't, honestly. So I know that may sound a little contrary to what I said earlier, but this whole idea of physician delegation is kind of a separate set of law from the EMS regs and statutes that we live under. And in some cases that might permit the kind of intervention you're talking about.
That makes sense. Thank you very much. I appreciate that.
Yeah, you're welcome. Yeah, sure. Other questions?
I've got one for you.
Yeah.
With this vaccine, I'm going to take it a little bit of a different direction. With this vaccine mandate, and with what we're dealing in the hospital, is that if people are coming to take patients out, you have to have vaccines or what do you call them? Not declinations.
Exemptions.
Exemptions, yes. So some private ambulances, and they don't collect that information. B, they're not, some places aren't comfortable with giving you that information. Where's that leave us?
A great question. So there is a vaccination requirement imposed on facilities. CMS did not go so far as to impose it on ambulance services. And folks, the reality is wherever you come down on the issue of vaccines, there are EMS agencies who have clearly learned that imposing a vaccine requirement on their people will cause them to not be their people anymore. Some people may vote with their feet, leave and go work somewhere else. So it's been hard enough for EMS agencies to recruit and retain people during the pandemic. But in some cases, the vaccine requirements that some EMS agencies have put in place have hurt in terms of retaining staff. So that said, if CMS has said that facilities have to ensure that people who provide care in their facilities are vaccinated, and I think you summarized correctly where we come down on the law, because CMS didn't really clearly address this. But if it's like a contracted provider, like doing a discharge transport would be, the facility can require that the agency provide proof of vaccination of the people who will be coming into the hospital to provide care. I don't think they have that same right if you bring patients in from 911 calls into the emergency department, because you don't have a contract with the facility to do that. I think the facility would be within its rights to drop the ambulance company's contract if it refused to comply with the facility's request to demonstrate proof of vaccination. And that puts the ambulance service in a very difficult place, because if they don't want to drop the hammer and put a vaccine mandate in for their employees, for fear they may lose those employees, they now have to choose between losing some staff members and losing contracts with facilities. So it's a very untenable situation, and an ambulance service can, as an employer, put a vaccine mandate in if they choose. But then there may well be consequences in the employment marketplace for doing that, and in the contract business as well, because a facility could go shop elsewhere. So does that answer your question?
It does, but that puts everybody in the pickle, because we have to get people out of our facility. But we're not in compliance because we don't have the documentation that CMS is insisting on. We're good partners with our EMS providers. We're not looking to, drop the hammer on them or anything. We're just trying to find that magic workaround that makes everybody happy. I mean,
yeah.
Political views aside.
Sure. Yeah, that's very much not a political issue. It's just the reality of the situation. You described it very well. I don't have a magic bullet, but I think I have my own views about the vaccine, just like everybody else has their own views about the vaccine. But my views don't count any more than anybody else's. So yeah, it's a tough situation, and Look, I have to say, we don't have a lot of precedent on how CMS may or may not be enforcing that. And honestly, I think if a facility can document that it made good faith attempts to identify ambulance services who had a substantial number of vaccinated employees, occasionally one came in that they didn't have proof of vaccination for, but the facility said, look, we got to move these patients. We are doing everything we can with our EMS partners to verify vax status, but in some cases, we don't have the luxury of 100%. I can't see CMS coming in and, blazing, complaints and all that kind of stuff. Just my opinion, though.
Okay, well, I appreciate it. Thank you very much.
Yeah, my pleasure. Other questions? We got about 5 minutes.
Doug, I have a question.
Same situation with the COVID testing requirement that CMS put out for the contracted facilities, and it was extremely difficult for them to track the EMS employees that were contracted with them on getting their positive or negative COVID tests for the week. So I think we're going to run into a lot of the same issues with.
Yeah, I agree. Yep.
Doug, quick question. It's a follow-up to what Matt had asked. So you had mentioned with the CMS in the facility, if you have a person contracted for that facility, but is not involved in direct patient care, let's say it's a law enforcement officer providing security detail, are they required because they're contracted with the facility to be vaccinated?
I think so. I think the CMS mandate went beyond patient care areas. I have to go back and reread that. I haven't looked at it since it came out, and we published a whole bunch of stuff on it. But if they're not, I could be wrong about that. If they're not in a patient care capacity or exposed to patient care areas, the mandate may not go that far. I apologize. That one's just slipping my mind. Feel free to shoot me an email or hit me up on LinkedIn, and I'll get you an answer. That one just because I'm more into the EMS side than the hospital side. So
Thank you.
yeah,
And
sure.
Joe,
Sorry, I
just as a
couldn't.
point of reference, at Steward, we require all employees to have one or the other, and anybody who's contracted here, whether you're contracted for linen or contracted as, EMS taking outbound.
That's helpful. Thank you.
I have another question that's EMS related now, and it goes back to your information on abandonment. It's very interesting. One, I just want to tell you this presentation has been tremendously informative. So thank you very much. So let's say a crew brings in a patient into the emergency department. Let's say that this patient, maybe let's say it's an asthma patient. They have an IV, running, and they've administered some medications. They have a monitor on, and so they want to go ahead and leave the patient because they got to get back in service. And the only person is the ward clerk that they could actually give the report to. Is that acceptable, or would they have to ensure they gave a report to somebody who would understand the condition of the patient?
Well, that's a good question. I think if I gave a field note or a quick sheet to somebody, they don't necessarily have to understand it to be able to relay it to the people who do understand it. But if I brought the patient in with an IV line and a cardiac monitor, I think the first question I would have is DCing all those, is discontinuing all of those interventions appropriate? And if the answer is yes, this was a TKO and this was the monitor showed nothing. It's why I use a monitor, because if it reveals nothing, we know, so if those are clinically sound decisions, I still don't I stand by my earlier statement that it doesn't have to technically be verbally face-to-face to somebody of higher credentials than us.
Okay, it makes complete sense then. Thank you.
Yeah, sure. I think we have time for one more before we have to wrap up.
Hey, Doug, I have a question that was sent to me. One's very brief and the other one maybe just there's two, but one is, does a BLS ambulance have to go to the closest ER no matter what? I'm inclined to say no, but what are your thoughts on that?
No.
Okay. And the next one is from Warren, Ohio to the Cleveland Clinic is about an hour and 15 minutes. And we get a lot of people who want to go up there for the specialized care. And so the question was posed to me that how far is too far? And by bypassing other hospitals, what's the legality of that, to taking somebody to a Cleveland ER versus the Youngstown, Warren area that is an hour and 15 minutes away?
Yeah, I think this is always a combination of sort of operational policies plus patient choice. We don't have an absolute obligation to take a patient any place they want. I mean, I live in the Harrisburg, Pennsylvania area. If I picked up a patient and they said they wanted to go to the Cleveland Clinic, I'd say, sorry, that's not in our coverage area, and that takes our ambulance out of service for an inordinate amount of time. So I can have a policy that says we transport to these facilities, right? And out of the area, then we'll take you to one of these. You arrange for interfacility transport if you want to go there. So we don't have an absolute obligation to take them any damn where that they want. But how long is too long? It's all those factors: patient choice, my operational policy for my agency, what my protocols say, and all of those factored together. There's no arbitrary number of miles. I will tell you, some of the Medicare carriers around the country have numbers that trigger mileage reviews if you go beyond those. It doesn't mean that has anything to do with clinical decision making, but the Medicare contractor here, by the way, just put out a thing that says if it's more than 126 miles, not sure what orifice they pulled that number out of, we're going to require further documentation. I've seen 50 by some of the MACs. So from payment, there's been some numbers attached to it, but from clinical, there's multiple factors to answer the question, how far is too far? Okay, so with that, let me turn it back to our hosts. And I just want to thank you guys for the invitation to do this. And thank you for all of you for the great questions and for the great attention that you've all paid throughout the 3 hours here. So thanks very much.
No, thank you, Doug. That was like Joe said, that was great. That was really, really informative. I think it answered a lot of questions, and I learned quite a bit today myself. Things that I've thought were true for 30 years really aren't, just because somebody told me that 30 years ago. So I really appreciate that. I appreciate you sharing your knowledge and your talents. Thank you so much.
My pleasure. Everybody take care and be well.
Thank you, Doug.
All right, for everybody else still on the call, if you are signing in, this happened the other night. If you are signing in, please put your full name in your login when you do that. There was somebody who joined the Teleflex training, and all we have is Rich. So if that's you, please email me individually, because I have to issue individual CE for those who are in attendance, because Teleflex did not allow that to be recorded. Also, there was a question posed about what happens next when this is over. If you've completed all of the makeup classes, or you were in physical attendance, and we can track that via the login via Microsoft Teams, then at the very end, once we collect our data, that we're going to issue you a specific certificate that will override the other ones that will say, for example, Larry Monero has received 60 hours of continuing education that meets the NCCP guidelines in the state of Ohio for the including pediatrics, geriatrics, traumas, and cardiology. So that certificate will be a very specific certificate. So if you do not meet all the requirements, or there's still a class that is not that you did not make up, you have until March 15th, and that's when we're closing our classroom to do the administrative work on the backside and auditing and double checking the attendance sheet. So we will make sure we get the appropriate certificates to you if you've completed everything. If you have not completed everything, then you would run forward with the certificates that you printed out via the quizzes, and we'd issue the certificate for the live logins. Also, we know when you come in and out of Microsoft Teams. So like, for example, the Teleflex end of things, there was somebody who, didn't come in for an hour afterwards. Unfortunately, that was unable to be made up. So you would get a half hour of CE for that. So we've got to be very diligent with what we're doing. And, when we get audited by the states, we have to prove everything. So those some questions that people have asked me. Other than that, on Thursday, we have Chip Comstock and Renee Waldo going to talk about additional legal issues in EMS and documentation to kind of help save in case you would ever have to go to court. Anybody have any questions before we wrap things up?
Hey, Larry, I got a quick question. It's Robbie from up in Andover area.
Yeah.
My EMT, my certificate actually runs out on the 3rd of March.
Okay.
I'm sure we'll have it back if I do get audited for some reason in time, but it's going to be dated before that, right?
Yeah. So the official end course was March 1st, right? So that'll suffice. That'll come in underneath it. Yeah.
Okay. All right. Thank you.
You're welcome. All right. Well, if there's nothing else, everybody be safe tonight, and we'll see you guys on Thursday. Thank you.